work and others, is let me just turn that off, is the NICE guideline. So that this is the first NICE guideline on mental health rehabilitation for people with complex psychosis. And it came out in 2020. The quirk is included as a recommended tool for monitoring quality improvement. But more importantly, that guideline says that we need to have specialist services for people who have especially complex mental health problems. Because if you don't, as you go through a process of deinstitutionalizing, all that happens is that that group get reinstitutionalized in various ways. And we've done lots of work on that theme. So that's very much captured in that guideline. And the reason I'm going on about the NICE guideline is because many countries will refer to the NICE guideline for different aspects of healthcare. So it's a very sort of influential publication. I was then also involved in this European Commission policy on longer term mental health care that was led by my good friend Jose Miguel Caldas de Almeida, who used to be the WHO mental health lead in the Pan Americas, and then he was the mental health policy lead in Portugal. Clearly, some people in the audience may know him too. Lovely man and really wonderful to work with on a project like that. So this sort of gives you more weight. It's great to do the research that you can do, but the more big names that you can get alongside, of course, the more impact you might be having. And then there's been some ongoing work in Australia, again, a country that is often seen as quite deinstitutionalized, but actually has pockets of really long-term institutions in Sydney, New South Wales, in Victoria, and in other states. And so we've had various collaborations, and these are two policy documents that have been specific in Victoria and in New South Wales that are really trying to do something different and to work in a way that allows the utmost autonomy for people with the most severe problems. It seems to not be moving on now. How did you do that? It's like magic. Okay, cool, great, thanks. And then the other thing that's sort of been a spin-off in a way from getting involved in this field has been working with the European Psychiatric Association a few years ago, because they were very interested in trying to improve the situation in Bulgaria, which has been known for a long time as having really very patchy and often not terribly good quality, particularly longer term mental health facilities. Bulgaria were involved in our original project, and one of the striking things was understanding the difficulties of that context. It's very difficult politically. It's really difficult to get synergy across different parts of the mental health system because there are a lot of factions who fight for resources. And the impact that has is that in some places you have really, really terrible longer term mental health facilities. And so we visited a lot of those as part of this project. I can't say that necessarily that work has led to a huge improvement, but it draws attention to what's not okay, and again gives people who do want change in that country the support of an outside body who have some degree of influence. So that's been interesting. And then more recently, the Portuguese Ministry of Health have funded a whole program to improve longer term mental health care. And this has included building inpatient mental health rehabilitation services, which are for this group with very specialist needs for short-term treatment in order to prepare them for successful community living. So that's very much operating on a UK-based NICE guidance compliant approach. And so this is a building that they've been renovating the inside of in Coimbra in the middle of Portugal. They've got centres springing up in Lisbon and Porto as well. And so it's great to be involved with that. And you also see that you have to get your jacket to match the outside of every building. And then the final thing I just wanted to say is, of course, ongoing research is enhanced beyond belief, really, by the people who want to work with you. So you get, we get approached by people who want to do our MSc. I teach on various MScs here and elsewhere in global mental health, and these are two of my current international PhD students, Sophia El-Nuzani, who's done this really interesting qualitative study looking at inpatient mental health rehabilitation services in Morocco. She's Canada-based. She speaks French, Arabic, and English. So she's been in this unique position of being able to interview people and translate from two languages back into English her data. And it's a fascinating project. And then Jorge Ortiz, who's with us today, and I'll just embarrass him by pointing him out, who started with us last September. He's from Chile, and he's working on developing a tool to be able to measure the degree to which different countries have deinstitutionalized. So it's ongoing, and I suppose the point being that you just have to start with one good idea and lots of good things flow. I'll stop there.
Hi, everybody. I'm Dave, and I'm at the Institute for Global Health. Thanks, Rochelle and friends, for inviting me to this. I think it's going to be really interesting and enjoyable, certainly for me. I'd like to say I've got imposter syndrome because I'm not really a mental health person. But then Rochelle said, because I'm old, I don't need to be because it came to be somewhere during my life. So I'm going to tell you about three things, and I suppose the underlying theme, and we can talk about this afterwards more. The underlying theme is mental health as part of life lived experience and not as separate from your experiences. And in this case, most of what I'm going to talk about today comes from India, more specifically Mumbai. And as lots of you will know, that there's a group of us who've been working on community participation for health for a very long time now. And as is illustrative of some of this afternoon's discussions, a lot has changed in the language. So we used to talk about participatory learning and action. And now when people ask about our work, we talk about community mobilization. And this is a picture of a group of women in an informal settlement in urban Mumbai. And lots of people have been involved in this work, some of whom, including Lou, who you'll hear from later, are on this screen. So this is not a picture to really look at. It's just to show you that we can do proper things, even if other people don't think they're proper. So this is a cluster randomized controlled trial of community mobilization to respond to and prevent domestic violence against women in Mumbai. And we realized quite a long time ago that although there is some mixed opinion on the value of complex trials of social interventions, they do give you a very large framework from which to nest other questions and to learn about other things. So the Sneha Tara trial, which was conceived and run by our colleagues Sneha in Mumbai, led by Nireen Darawala, who is a proper mental health professional, a clinical psychologist, and that was completed and it was published just before Christmas. And I suppose again, to return to the underlying theme of mental health as being part of everything else, this rather complex diagram of a rather complex intervention shows that mental health support is part of the case work and case management to support survivors of violence against women, along with legal support and social support. And it gives us the opportunity, and what's, I think, like what Helen was saying so articulately, it gives you the opportunity to look at other things. So our colleague Suman Kanugia became interested in the differences between mental health and mental illness. And this, I think, may be a theme in this afternoon. And rather than the end of what are now often called severe mental disorders that Helen's been talking about, the group of people I work with are largely interested in common mental disorders, anxiety and depression, anxiety, depression. And all of this happens in a world in which all of this stuff has been contested globally. So there's a large literature on what the hegemony of the northern medico-industrial complex, the medicalization of differences in normality, etc., the meanings of different mental health labeling. And so just out of interest, we had become interested in mental well-being, and this is the short Warwick Edinburgh mental well-being score, best acronym ever invented. And these are really, really simple charts where on the y-axis you can see two international scorecards, the PHQ-9 and the GAD-7 for anxiety and depression, or are they? Plotted against scores for well-being, and showing you that although in most cases, 78% and 81%, those things coincide. So if you have a positive GAD-7 score for anxiety, you will have a mental well-being score that suggests that your well-being is not good. There are lots of other parts, lots of other quadrants that have other populations. So there's a debate, which I'm sure we'll go into this afternoon, about what's mental health, what's mental illness, what's mental well-being. And so here's another really simple to interpret diagram. It goes from the top downwards and from left to right. And this is part of a large NIHR global health research group led by Delan Devakumar that involved a number of our colleagues in a number of countries, Sri Lanka, India, including Sangat, that some of you may have worked with, and Afghanistan. And what we're looking at is terminologically these different columns on the left, which we've called outside and inside. And this was a key problem that occupied the first 3 years of this group. The mental health people wanted, I'm being blunt for fun, wanted to do mental health interventions. The not mental health people wanted to do social and instrumental supportive interventions. If people feel they're under threat and they have no money and they can't leave a violent partner for those reasons, there is a tension between the argument that they would benefit from those circumstances changing, their mental health would improve, or some sort of specifically mental health intervention. And I'm sure a lot of you are aware of this literature, but it's very, very interesting, and it caused lots of spirited discussion. So we called those outside and inside. So outside was things about your environment that you're experiencing, and inside is how you are feeling and how you are thinking. And then we thought about this other discussion that was playing out all over the world about who should provide the care and task shifting, etc. So most people who are survivors of violence, certainly in Mumbai, but in all the countries actually that were involved in the group, get support from what are now called case workers, because some people think they're not qualified counselors. So they're often in the non-government sector. Sometimes they're in the public sector. And that those people, the question is, to what degree should those people be able to provide mental health support? And our summary answer is, that there's a small but important need for specialists, but that the key issue was trauma-informed interaction between the clients and the service provider, and we can talk about that later. So this was incredibly interesting and important, and it led to the development of this tool, which is, we think, not the world's first ever interactive online tool for this. This is for use by case workers, but it's freely available on the web. And instead of, we can look at it, but I won't use the web, it'll mess everything up. We've got one for survivors of domestic violence, and we've got one that's orange, which is for survivors of human trafficking and modern slavery. And what it is that we thought people don't use manuals, and what they do is look at their phone on the bus. And so what you should be able to do is jump around between all the sections of this manual. So it's not a manual, it's always there, and you can just look anything up in any order at any time. And it's written in a number of languages. It goes quite deep, but quite deep into the kind of things that non-specialist caseworkers could provide. And I think that might be all I was going to say about that. If that's all right, Rochelle?
Then we can have a wider discussion. I have one question online, but is there anything in the room that, any questions or reflections for either David or Helen? You're sitting there next to us on the end. Yeah. It's for the online. The online. Yeah.
Thank you both. They were really interesting discussions. Nice to see Michael's name as well in your papers. Michael King, is at the Division of Psychiatry. David, a question for you about well-being. We have been also using the Warwick Edinburgh Mental Wellbeing Scale in Nepal. We found it really troublesome. It's quite interesting that there's been an awful lot of work done on cultural adaptation of concepts of mental illness, but very little literature that speaks to well-being. And I wondered if you could say a little bit more about how well you think that the components of, you maybe can answer this, hopefully, how well you think the components of that tool and the components that we understand as well-being in the UK map onto those models among your sample in India.
Is this on? Yeah. Thanks, Kelly. Simple question, which, there are two answers. There's a straightforward, provocative answer, and there's a more nuanced answer. So I think the answer is probably lots of people have had lots of trouble using this in different countries. And people, one should always avoid generalizing about cultures. It's a big mistake in some of the literature in global mental health, but sometimes when you ask people the questions in the Swemba rivers, people don't really understand the questions, even though they're in their own language and they've been validated and people have been trained and everyone understands them. People don't identify necessarily with the concepts that you're pointing at. And that's a really big issue. I'll give you an anecdotal example, which is, I remember asking someone if they were enjoying their job, and they said, "What do you mean?" No. It is quite northern to talk about whether I feel fulfilled, whether in general I find my life satisfying, because lots of people don't articulate mentally those ideas. So although that scale's been validated and adapted, I'm still not sure. But then again, we're talking about the imperfection of a tool in the broader context of something that we don't really understand anyway. So what is mental well-being, and what is mild, moderate, and severe anxiety, and how do those things map onto each other? These are huge questions, which I wouldn't pretend to be able to start answering. Did that help?
Can I add something?
Yeah.
Because we use that tool in mental health services, statutory secondary mental health services here for many years. And I found it a very difficult tool to use with people with more severe psychosis, because the concepts don't chime at all, perhaps because of the particular way in which things like severe schizophrenia can affect your ability to abstract. But there's also and it's the same thing. If you've never experienced a sense of well-being, then it can be very odd to be asked, because you have nothing to sort of anchor that to. So although a tool goes through the phases of development, and we, tick the boxes of psychometrics, but it may still be useless.
Proper mental health.
Yeah.
I mean, I was really relieved that you asked that question, Kelly, because it's sort of when our work in Nigeria, which was on was a pneumonia project, looking at reducing infant mortality through PLA groups led by Tim Colburn in our institute. I was their community methodologist person then, and I said, we should also do something on mental health. And we said, okay, well-being, let's use the WEMWebs. And it was the exact same thing, where we were just like, actually, this holds no relevance. And so then we did this interesting piece from it that we built into our ethnography, because we did a ethnographic process evaluation. And basically, we came up with a local framework for well-being that basically that we think would potentially replace something like a WEMWebs. But like, it's not until you use it and it doesn't work that it pushes you to say, okay, well, what is the concept here? And it was really nice to be in a trial or in a space, like you said, where you have space to sort of move and meander and engage with those other questions, and sort of to feel comfortable saying, what happens if you started from zero? And actually, it sort of came up that it wasn't working, because women said that when children were healthy, their well-being went down. So that's what the measure said. And we were like, how could a healthy child make you feel worse? And then when we talked to women, it was like, actually, there are very few spaces for us to exercise agency, for us to hold power in our lives. And we hold power in our lives when we're taking care of our children, when we're working to save them because people listen to us. And so actually, that's when their well-being went up, a space where they were able to sort of change their social relations and social and structural dynamics. And I think that's a really powerful, interesting complexity to kind of try and sit with when we're thinking about measurement, I guess, and making space for that. So that was amazing. Are there any other questions? Or Lorraine?
Just a fascinating discussion. So I wonder if anyone in your knowledge has looked at the absence rather than the presence. So could you correlate, or has anybody taken people scoring below cutoffs on PHQ-9 or the GAD-7 or whatever with any measure of well-being? So if you're not anxious, is it the same as, or is it a proxy measure for well-being? Because then we could turn all the studies on their head, and just, instead of focusing on the people who score above the cutoff, you could actually have some quite interesting data on those who score below the cutoff.
I'll have a go. So we're just beginners, but that is what the chart I showed is, because it shows that there are people who don't have anxiety, who have well-being, and people who don't have depression, who these things are not real things, anxiety and depression, but take that as read. So we've sort of done that, and there is discrepancy. So it is possible to. Do
you want to go back?
Yeah, you could. Thanks. Yeah, so one of the things that we think is interesting is that you could have greater well-being and higher anxiety. Sorry, lower anxiety and greater well-being. You could have greater well-being and greater anxiety. It's only 4%, but there's a 13% on the bottom left, which is lower anxiety. I'm getting it. Have we got it right? Right. So that's all I'm aware of. There may be other. This is about a year old. There may be other literature on it, but I mean, I don't know how. This is not my field. I don't know how valuable this stuff is. Whether I'm leading you down a blind alley here. I'm not sure.
Well, it reminds me of long-standing discussions and debates about quality of life.
Yeah.
And, the bizarre relationship between severity of symptoms and better quality of life. And similarly, we found again a kind of unexpected result around quality of life for people in residential care homes was higher than, this is again mainly people with schizophrenia, than people who are living in supported housing or in their own apartment having visiting support. And so our assumption is that, it's much better to be in the community and have more autonomy and your quality of life will feel better. Actually, we found the opposite. That's interesting, and it's very much, it was a national UK based study that isn't replicated in some other countries, which might be to do with what residential care is in different settings. But it was also perhaps correlated with the fact that the more autonomy you have, the more likely you are to be a victim of crime. So people with severe mental health problems are often targeted. About 70% of them will experience financial, sexual exploitation by others. And that's more likely the less sort of, restricted your environment, because obviously somebody's protecting the front door if you're in a residential care home and they're not if you're in your own flat. So basically confounders may explain quite a lot of it.
I want to go to the two questions we have from our online attendees. So the first one is for Helen. It's from Sahar Ibrahim. Where can we find the guidelines that you were presenting? Are they available for everyone? Are they online? Can anyone access them?
Yes, the NICE guideline, if that's the one, is there, available. Just search NICE guideline, NICE clinical guideline number 181. And if you can't find it, email me and I'll send it to you. Everything on the slides is available publicly, so we can just share the slides too.
Great, thanks. And then David, this question's for you. This is from Sumit Jain, from Edinburgh. He's in Edinburgh.
Hi, Sumit.
Hi, Sumit. Can you say more about the non-manual and how useful it was? And is the development process of this published anywhere for us to learn from?
Yeah. So how useful is it? Well, pluses and minuses. The minuses, and again, this is a collision of expectations. It was always my belief, and we did face lots of pushback, that we should make something that anyone could use with no knowledge and that it would be intuitive. Nevertheless, from the moment it was released, people said, can you organize a training course on how to use the website on the bus? And actually, Nyreen and colleagues have done that training course, some of it for government. And they didn't quite understand why they were doing it, but people expect stuff a bit like they expect a manual. And the reception of that course has been overwhelmingly positive, as you would hope, because it's quite intuitive. So they get shown it and walk through it, and then they discuss the issues, and people find that very useful. There have been quite a lot of things emerging from it, and the feedback, which I suppose we're collecting semi-systematically, is overwhelmingly positive. We had lots of pushback before we released it from within our own group, which was quite interesting. I'm going to do a sort of quote of one of my friends and colleagues who said, "No one ever reads manuals, so we're making a manual." And when we said, "We're making it all online so you could read on the bus," people always used to say, "No one's got internet, no one's got a smartphone," but you know, that's not the case now. So I think we think that this is good and useful, and it is being used. There are other issues, like I visualized a counselor using it live, but there are issues with that, because if you're giving your attention to a survivor, you can't like be a British GP and go on the internet. That was just a joke. So I mean, there's something about the provider client bond that you have to face them with your whole body and give people your attention. So what we were hoping was that people would nip to the toilet or look on the bus on the way home and look at it, or look at it that night, and that is what people do, I think.
Yes, Helene, I'll bring you the microphone. And I think this will be the last question for this session. But I think there's lots of integration across panels. So
thank you very much for both talks. I don't know this Warwick Edinburgh mental well-being scale, but I think what concerns me more generally is that you're centering things on anxiety. So that's very much a mental ill health centering, whereas actually I think if you think about the constituents of well-being, you go into life satisfaction, a sense of meaning, hedonic happiness, and then, so I think actually, I mean, we use in our works, I'm in psychology, but kind of anti a very individualist approach. And that I think you find dominates psychology and psychiatry. And I think using the Office of National Statistics, their well-being measure and their history of working on that seems to me much more useful. So we use their scale, which includes life satisfaction, absence of anxiety, sense of meaning, hedonic happiness, and there are various there are various adaptations of that. But I think maybe that's if the Warwick Edinburgh, and I need to see it, and I'm really intrigued that it exists. If it centers on absence of anxiety and depression, that is centering a mental illness approach too much. I think my last word is connectedness is unbelievably important. So I would imagine even with your domestic abuse survivors, just the sense of being connected to other women or sympathetic men, that would be, very important. But I'm really speaking out as an outsider looking in.
thanks, Helene. I did say that would be the last comment, so I'm going to try and hold myself to that and just sort of say a huge thank you to David and Helen for opening up our sessions today. And we'll just take a minute to swap over for our next chair and speakers. But your presentations were so good. I just sort of. Oh yeah. Okay. Yeah.
Hello, everyone. I'm Kelly Rose Clark. I am an old timer at the Institute of Global Health with a brief hiatus, a dark time at King's College London, but back here. That was also a joke. And I am a Principal Research Fellow in Global Mental Health and a UKRI Future Leaders Fellow. And I'm very happy to be here in front of you all today in the cool AC. I thought that the discussion we had just then about well-being, but also more broadly, really represents why it's fantastic to do global mental health at UCL, because you have all of these different disciplines talking across these major issues in global mental health. So we have the clinical, we have the social, we have the implementation, we have the psychology, the whole range. And it's really wonderful to be here where we can put all of those brains together and think about these big issues. Anyway, so I am here to chair this session on early and mid-career researchers' visions of challenges and opportunities. Having worked in global mental health since about 2010, I'm really, really proud to say that I think global mental health is a brilliantly dynamic, self-reflective, and able to, and has over the years, I think, been able to respond to some of its really important critics about the field, about the power dynamics, about our framing and concepts. And I think that over the years, there have been successive generations of global mental health researchers who have really participated in shaping the discipline. And I think this is a brilliant session because if you want to know where global mental health research is headed, you ask early and mid-career researchers because it's their work that will continue to move the field forwards. So without further ado, I will introduce our first speaker, Lou Graham, Dr. Lou Graham. Do I have the power of the button? Yes. Lou, do you want to come up? So we'll do, we'll run through the sessions, 10 minutes per session. If it's all right with everyone, we'll take questions at the end. We have a few pre-prepared questions, but then also we'll take questions from the audience and from online as well.
Okay, so I'm just setting up some of my notes. Okay, good afternoon, everybody, and nice to see everybody coming to this talk. So yeah, as Kaylee said, my name is Lou Graham. I'm a senior research fellow at UCL. So I work on community-based solutions to poor health, and I work across a range of topics, including mental health, as well as maternal and child health, racism and health, and prevention of violence against women. The common thread is that I tend to work on issues of structural discrimination and how it affects vulnerable populations. For this talk, I'm talking about my Career Development Award, which is an 8-year-long Wellcome-funded project. It's asking an important question about whether or not LGBTQ plus collective action can act as a prevention pathway for depression and anxiety. So the awards begins in July. So it's based on preliminary work, but obviously because it begins in July, I'm going to talk more about the rationale for the project and what we plan to do, rather than necessarily findings from it. So it's well known that LGBTQ plus people face higher risks of various kinds of mental health challenges. Systematic reviews consistently find that they face 2 to 3 times higher risk of depression, anxiety, and suicide globally compared to straight peers. And health systems play a role in this. Health systems often fall short. So systematic reviews also find that across the world, LGBTQ plus people report being refused care, referred to so-called conversion therapy, or discriminated against by mental health providers. In the global south in particularly, queer mental health is severely understudied, where the term LGBTQ plus health often becomes synonymous with HIV prevention in men. And we actually did a recent, I worked with colleagues on a systematic review of mental health interventions in Southeast Asia. And it was really striking given how we calculated that probably over 95% of LGBTQ plus people with common mental disorders didn't have HIV. But out of the 13 interventions that we found that reported mental health outcomes, all of them except one was only for HIV patients. Yeah. Other systematic reviews have found that out of 232 trials and psychological interventions for adult depression or anxiety, only 1 even reported on sexual orientation, and less than 6% of depression prevention trials have taken place in the global south. So there's a huge evidence gap, and this really shows in the kinds of interventions that get developed in global mental health. So these are some pictures from common policy documents and well-known interventions to promote mental health and prevent mental health challenges in WHO documents and so on. And they show how mainstream global mental health often relies on the idea of supports from sources such as the family, from neighbors, from social norms, from health institutions, that are precisely the structures that tend to fail LGBTQ plus people, whether through family rejection, prejudice from neighbors and colleagues, or exclusion from social and religious institutions. And so what queer people have always done is to try to improvise strategies to sustain life without these traditional support structures. And given how many 21st century societies are anyway changing, are, in the words of Zygmunt Bauman, turning towards ever greater precarity and atomization, what he would call liquid modernity, the collective experiences of queer people of coping with crisis and instability sit at the forefront in some ways of global trends. And I will give you two examples from our photo voice work on how queer people have build structures to deal with structural discrimination and address challenges in life, both from work we've done in Hanoi and Vietnam. So the first set of photos is from a wedding ceremony staged by a local lesbian artist in Hanoi. And you can see on the left, it's a wedding gift that one of the participants made for the wedding ceremony. And on the right, it shows the artist getting married. So since 2014, for over a decade, Vietnam has had a very ambiguous policy on LGBTQ plus marriage. So they held extensive consultations back in 2014, which raised hopes among activists of legalization of same-sex marriage. But after all these consultations, the government ultimately decided just to make it not illegal, rather than to actually recognize it and give people rights. So in our study, participants often experience severe distress from the lack of family and societal recognition of long-term, years-long relationships, to the point of participants breaking up with long-term partners and one even voicing persistent suicidal ideation over it. This artist staged a joyful ceremony, perhaps in protest, perhaps also because she found traditional heteropatriarchal marriage structures a bit limiting. She put her own spin on the wedding ceremony. So I'll read you a quote from our participants. So the picture on the right, this is the first set, the first wedding session. She married a person there. The next day, she went ahead and married 10 more people. So at this moment, she's wearing a wedding dress and a white wig. It's countercultural in a lot of senses. Everyone can see that there are two brides here, one of whom isn't even biologically female. When they said their words of connection to each other, I felt happy and healed. And the wedding ended with her marrying an effigy of herself. And so I found that my view of weddings changed after yesterday. In this photo, you can't really see anyone's face clearly, but I think here everyone can see the happiness. It's joyful in both a physical and spiritual sense. We thought this could be some kind of future vision for the LGBTQ plus community. So the queer theorist Esteban Munoz talked a lot about queer futurity, how queer people, by living their lives and enacting different social forms, in some ways are presaging a kind of future social arrangement, a kind of utopian future that straight people also engage in when they open up social norms and try to live with different kinds of social arrangements. And to some extent, this represents that kind of moment for me. The second set of pictures is a different story. So it's on the left is a self-portrait drawn by a trans community activist in Hanoi. And on the right, it's pictures from a banner of a trans health clinic that the activist opened in 2020. At the time of the photo, she states in her own word that this was a happy photo, but now the meaning of the photo has changed. She opened the clinic with the dream of providing much needed services for trans people, such as advice on hormone replacement therapy, mental health counseling, and PrEP services. She invested almost £40,000 of her own money into renting a 5-story building, hiring staff, procuring equipment, and then waiting for approval from the Ministry of Health, which never came. So after 2 years of waiting for approval, losing tens of thousands of pounds of money to rent and staff, she had to close the clinic. And coupled with other setbacks in her life circumstance, she became depressed and also suicidal. She said in her own words, "When I stopped, the thing I regretted most was that when I decided to stop at that moment, it was like I was ending one of my dreams. Like maybe I wouldn't be able to work for the community anymore because I felt like I'd spent too much energy on it already, but I still keep this photo as a memory." And the second example for me shows you how in a lot of mental health work, we rely on this idea of a benevolent planner, of a benevolent government that sort of builds institutions, builds services. But for a lot of queer people all around the world, not the least in countries where it's illegal to engage in same-sex sex, you can't assume a benevolent planner or a benevolent state. Also, for me, the two examples I show you show the extraordinary lengths to which LGBTQ plus people go to self-organize. They create what the philosopher Laurent Bellon calls affective infrastructure, the kind of social and emotional conditions you need to survive crisis and instability. And it shows for me how individual mental health and community organizing and activism are all entangled together rather than neatly separable domains of inquiry, and how powerfully possible and necessary it is to go beyond individualized biomedical treatments for poor mental health when there are broader structural drivers of ill health. So this project is trying to grapple with questions about how to address depression and anxiety among LGBTQ plus people through bottom-up collective action. It asks, can LGBTQ plus collective action prevent depression and anxiety? And that can go through many different forms, whether we're talking about pride events, drag shows, online organizing, some of the examples I showed you before. There's preliminary evidence from outside of queer studies showing how collective action can prevent mental illness, whether we're looking at women's groups in India or livelihoods groups for men in South Africa or youth social action groups in the UK. But the evidence base is quite fragmented and far from settled. So we plan to do a more in-depth study on this in the Wellcome Fellowship. So I have 3 work packages through which we try to do this. So work package 1 is a qualitative work package which asks questions about what forms of collective action take place in Vietnam, how do they shape mental health, and we're going to do a grounded theory study to map out indigenous forms of queer collective action and then develop a typology and theorize how they relate to mental health. And the work package 2 will test these ideas quantitatively. We aim to recruit a cohort of 1,500 LGBTQ plus people, follow them for 2 years, use respondent-driven sampling, and conduct cross-lag panel analysis. And then work package 3 will then provide a third epistemic lens by asking what happens when we then translate it into intervention. The aim is not to test efficacy, but to assess feasibility and then center the voices of queer Vietnamese people themselves, who after all are the ones who have to live with the consequences of the public health recommendations we make. So I'll end with a brief overview of the vision of the project. So right now, if you ask, if you just pick a mainstream public health researcher off the street and ask them, can queer collective action prevent depression and anxiety? They'll probably look a little bit confused and be like, what do you mean? And I think that's because we don't really have a standard shared frame for making sense of this question. We don't have an agreed definition. We don't have an agreed theory. We don't have an agreed measurement tool. We don't have causal evidence. And so this project is about trying to supply all that. It's about trying to just make the question in the first case of how collective action relates to mental health legible to public health. So then future researchers into LGBTQ plus mental health don't have to start from scratch. That's it.
Thank you so much, Lou. On to our next speaker, which is Jivan Tor.
Hi everyone. So I'm a PhD student at the Institute for Global Health, and I'm in my last year of slowly writing up everything that I've found. So I worked with Inuit youth in Winnipeg, in Manitoba, and also in the Arctic, in a very small hamlet, to understand local conceptualizations of health and well-being, which were grounded in the Inuktitut word of Kenuintik Ortik site, which means health and well-being. So I primarily spent time in Winnipeg. That was the main focus of this work, because there is a growing urban Inuit population in many centres, such as Ottawa and also Edmonton, but Winnipeg being one of them as well. And due to the lack of recorded perspectives of health needs, health gaps, and particularly youth experiences of their own well-being. I also got a small fieldwork grant to go up to the north, so in the Arctic, and I thought that was important to kind of gain an understanding of where people were coming from, given that a lot of the youth I was interacting with in Winnipeg had recently moved from northern communities, or they still went back if they could. And a lot of other community members as well often frequently went back when they could, or had a lot of family still up there. And so this opened up kind of an unintended comparison that I was able to gain from spending time with both groups of youth, despite the Arctic time being a lot more limited. So I found that youth really face a lot of structural and institutional barriers to their well-being, a lot of legacies left over from colonialism that are still faced. In the urban and northern settings, there are like different structural specifics that are different, but overall it's through the education system, through the healthcare providers, and the child foster care system failing these kids basically. And while I don't necessarily anchor my work in global mental health, but we've spoken today, or it's come up a lot, how that means a lot of different things in a lot of different settings, and it's kind of a fluid term. I've found that the literature in the field and discussions around this kind of area have allowed me to think critically about what mental health actually is, and if it's a helpful term to frame topics such as this, or if we should maybe just move to more broader localized understandings, where when you talk about things like this, it should be health and well-being if you're talking about it in English, and if you're looking at it in a specific community, maybe you need to kind of go back to the basics and build up from there. Now, saying that, a lot, some of the urban youth I was working with didn't have knowledge of their own language. So that made it a bit awkward in some ways, because they wanted to learn. That was one of the things. They wanted more cultural programming. That was one of the things I found, but I felt awkward putting this concept onto them. But the kids in the north knew the concept, and so did the elders, and that were guiding the program, and the wider community members as well. So I think, yeah, so this field has been useful in the literature around it, about thinking about those kind of questions and kind of guiding my investigations as well. And while I didn't really address this directly in my work, it did come up, and we've spoken about this already today, the limitations of established mental health assessment tools. So a recent trial that some colleagues were working on in one of the Arctic hamlets found that basically the PHQ-9 did not resonate with anyone at all. They didn't get enough data, and the only thing that they did was translate the tool into local language. And I kind of had some suspicions about this before they went and did it, but it confirmed the fact that I've been speculating with other colleagues that I mean, I'm sure this is true for a lot of people, but specifically here, having a relationship with your healthcare provider is really important. And for those that live in the Arctic, they are often met with transient healthcare professionals that don't stay in the community long term, and who are not from their community, and that have little understanding of the intergenerational trauma, colonial legacies that are faced, and overall social inequities too. And of course, some of those aspects are met in urban settings as well, where youth actually said that cultural competency in childcare services and healthcare and education was something that they wanted to. So that was a parallel in both places as well. And so just a couple of pictures here from some of my time out there. So I did a lot of participant observation, relation building, hanging out with these groups of youth. And I also did some arts-based engagement activities, which you can see there. So I put on some workshops, or I facilitated workshops, I guess, and activities for them to do around the city. So going to a corn maze because it was Halloween. One time I was there, and then another time was a printmaking workshop at the local art gallery. And then I did photo voice activities with the Winnipeg youth, as well as body mapping and River of Life as well. So I'll just end there.
Thank you so much, Jivan. I think you've also answered the first of our pre-prepared questions. Extra points. Katie Atmore, do you want to come?
Thank you. I don't have any slides, so you might just have to continue looking at Jivan's, which is fine. So my work, somewhat unsurprisingly, is quite similar to Jivan's in that I'm doing cross-cultural work. So my PhD with Kelly is looking at the relationship between school culture and adolescent mental health in Nepal. And today I wanted to speak a little bit about kind of my ongoing kind of high-level reflections on my own PhD process and that kind of reflexivity part where it feels like actually the most interesting piece of the research is why am I doing this and for what purpose and who am I to be doing this kind of in that kind of global context. So I'm thinking a little bit about opportunities and challenges of working cross-culturally, specifically in qualitative research that's reliant on translation. I'm sure almost everyone in this room has worked in cross-cultural projects where you're working between multiple languages and cultures. So I've been reflecting on that a lot and just wanted to share a few of my thoughts around how that all sits together and what it means kind of more broadly for global mental health. So a little bit more about the project itself. So I'm working in Nepal, and that's particularly interesting because, well, I think a lot of people have also worked in this room in Nepal, and why people do a lot of research there, it feels like, is it's a low-income country or lower middle, but it's kind of on the precipice of having good education systems and research systems. So it's just easy enough to do research, but there's also kind of really prevalent issues of poverty and other difficulties in society. So it's almost like that golden intersection for researchers. What's really interesting then about the youth in that population is that in the population where I'm working in Chitwan, you have a lot of kids who are kind of in semi-urban areas, but their parents are subsistence farmers, but they've got a smartphone. So there's this kind of two real worlds that collide and overlap of being very connected to kind of the digital world, the Western world, high income kind of news and media, and also being very connected to a very culturally different way of life that their parents and kind of generations behind them have been in. So that makes the research very interesting, but also somewhat complex to get your head around. So I did, and I use the term I a little bit loosely here, I did qualitative interviews. So I had a research assistant who helped me with qualitative interviews that were done in Nepali. And there was a lot of thinking around how to do that. So my questions were around mental health of adolescents and how this impacts their experience of school and how the school culture impacts the mental health of adolescents. So when designing the research, the semi-structured interview guide, had to think a lot about not putting words or my words, my Western psychological, medicalized view of mental health into the mouths of these young people, and then get that immediately reflected back to me. So the way we worked around this was using vignettes of depression symptoms. So rather than saying, tell us about your depression, we said, picture a student, they used to be happy, something's changed in the student's life, they now don't want to come to school anymore, they've stopped hanging out with their friends, and then ask the student if they related to that story and to speak a bit about if they've had their own experience of it, what would they call it? So that was really trying to encourage them to use their own words to describe these kind of experiences around mental health. That obviously, my project's conceptualized in English, then the interviews happen in Nepali and then gets translated back into English. So that's obviously complex enough, but I've also been reflecting a lot on other forms of translation that are going on. It's not just a linguistic translation. There's so many other levels to it. So there's also cultural translation. So do concepts that exist in Nepali come back with an equivalent word in English? Often the answer is no. If I use 2 or 3 different translators to transcribe my transcripts, then there's going to be differences between the transcribers, the translators, or even a single translator might write the same word differently on a different day. There's also age translation that goes on. So if the research assistant asks a question, are they using a kind of colloquial language that a teenager would use to kind of assimilate? Is the teenager then using a language which is then translated again to make it a more scientific word that I, as the English researcher, are going to be more familiar with? So there's so many levels to it. There's also gender translation. My interviewer was a woman, but does that mean that the boys are speaking to her differently? So there's loads of layers to this, and also kind of scientific language. If I conceptualize it scientifically and then translate it colloquially, what happens when it comes back? So these are things that I've been just ruminating on constantly and wondering if any of my transcripts have anything that has any level of truth to them. But I think, you have to think of it in terms of the wider data set and what the patterns are. And I was speaking about this earlier, and there's a real grief, I think, that happens in qualitative research where you have all of these transcripts and case studies and you go, oh, well, that's the girl who lost her sister, but now she's living with her auntie and she moved schools. But those individual cases get really lost when you try and summarize and turn the data into these kind of recommendation points. So, well, I'm sure you all kind of relate to these points of translation. So I guess moving into my kind of hopes and more positive elements, not that these are negative, but more just things to think about. I've thought a lot about the role of AI going forward for translation. Think that it's a really exciting time. I think there's so much negative media around AI and it kind of decimating individual stories, but the idea of using it as a powerful tool to kind of deconstruct English language peer-reviewed hierarchies where everything has to come back through to the English world of people being able to write in their own language, doing research in their own language that can kind of be automatically translated into whatever browser you open it up, whether you're in France or in Papua New Guinea, and you can just see it in your own language. Obviously issues in translation there, but it can make data a lot more available if we kind of lean into those systems. Other positive things is the kind of power of youth-led research and co-production. So funnily enough, although I was really encouraging these youth not to use these kind of Western medicalized concepts because they're all on their smartphones and they have access to social media, a lot of them had a lot of mental health knowledge and resilience built in, a lot of terminology that they were able to reflect back. So it's a kind of interesting balance of whether you're trying to use this kind of colloquial terms or whether you actually assume a quite a high level of knowledge of these young people in kind of lower resource settings. So those are my general thoughts of working in this field, and hopefully, moving into more positive ways of translating and kind of celebrating those different perspectives.
Brilliant. Thank you so much. Thank you, all of you. Would you all like to come up and take these very formal seats here so we can ask questions? Rochelle, are you able to field questions from online? Yeah. Sure. I've slightly reworded them. I hope that's okay. Marginally. I think it's brilliant, and I'm not disappointed in the sense that I feel like global mental health is very safe in your hands. These sort of emerging themes across your talks, I think, kind of centered on expanding our kind of traditional breadth of global mental health work to encompass neglected populations, thinking about the LGBTQ plus in Vietnam and contexts in high income countries, the Inuit youth. I think we've had and known for a long, long time that global mental health research needs to incorporate lived experience and youth voice. I think that's been around, but what I hear from your work is just the centrality of that. That being the starting point for this work, and the really innovative ways within which you've engaged those groups within the research that you're doing. And I still hear the same kinds of issues that I've been struggling with my whole career, in the sense of this tension between the desire for something that has universal weight, universal meaning, versus the very local conceptualizations, and trying to hold both of those in the same research project. Hearing that just in terms of your concepts of mental health, but also your interventions, your measurement tools. And I think also this sense of, as Katie, you were saying, the sort of complexity, holding that kind of rich complexity, but also needing to have something that is kind of functionally simple to disseminate. So yeah, I think some really interesting trends, themes, messages coming from those. So on that note, I think starting with the first question, which Jivan has, I think, really beautifully articulated her answer already, what global mental health means to you and how does it inform the work that you do? Do you want to say any more on that, Jivan? Yeah.
Oh, you yeah, just kind of leading on from what I was saying about how we conceptualize mental health or health and well-being. I think we kind of need to think about what we are wanting to gain from doing this. Are we wanting to help people heal from whatever they need to heal from? So in my case, it's a lot of intergenerational colonial trauma, as well as systems and institutions that are very like Westernly orientated. And within that, so I kind of touched upon the screening tools and my perspective on that, but then also the idea that kind of what these labels mean for the people that you're giving them to. So a lot of youth kind of came to me and said, oh, I think I might have ADHD or I might have depression. But when you kind of unpack and learn a little bit more about their lives, you just think maybe it's just your lived experience. And the label helped them make sense of what they were going through, but the medication that they were then put on without any kind of follow-up or appropriate treatment, however they envision that being for themselves, doesn't necessarily help to heal, I think. And also this kind of work has opened up the ways to which labels can also have superficial help. So in that example, it can help the individual make sense of their suffering and their life. But then also, I have a colleague who's a psychiatrist and worked in the same community up north for a very long time. And she will give PTSD diagnoses to people who are entitled to residential school reparations, because that's the criteria that you need it for, which doesn't help that person, but they get something in a different way for it. So it's kind of how I think the labels are also politicized in various ways, was very eye-opening to me as well. in this kind of field and how we think about mental health.
Lou.
Does it work? Oh yeah, it works. So yeah, I mean, it's an interesting question. So I mean, I came into this field from adjacent fields like prevention of violence against women or maternal and child health, and I think what really struck me when I first started was how global mental health was such a polarizing term. So you came into the field and then literally people ask you like, are you pro or against global mental health? Yeah, that's like the first thing. And it was like, you have to take a position. And then later on, you learn about the discourse around the treatment gap and health seeking and mental health stigma and all of that. And I guess my reflections on it is that I guess if you speak about mainstream global mental health, that it is a part of the picture that, you know, in Vietnam, there is a huge lack of access to mental health treatments. There is a huge amount of mental health stigma. There are all these cost barriers to treatments. But what kind of struck me when I talked to LGBTQ plus participants is that many of them in our study, had been in psychiatric institutions, they had been to treatments, they had got medicine prescribed, but they really talked very little about it. They really talked very little about mental health stigma or medicine, unless you really prompted them and asked them specific questions about it. But what they talked a lot about was LGBTQ plus stigma and all of their experiences with it. And so I think, for me, it's like it provides a part of the puzzle, but maybe not all of the puzzle.
Can you repeat the question?
What does global mental health mean for you, and how does it influence the work that you do?
Yeah, I think you're right. It is a funny term, and you wonder, does my work have to be kind of cross-cultural in order to be considered global? And I think I find it much easier actually to identify as someone who's researching in adolescent mental health or women's mental health, because that concept is much more kind of fixed, and the global element, I think, for me sometimes just means, oh well, I work in different places. So yeah, sometimes I think it's not super helpful to try and think about myself as a global researcher, because I don't research the globe. I research very specific populations around the globe. So sometimes I actually actively shy away from it, even though I do still feel part of the global mental health research community, rather than me researching global mental health, if that makes sense.
Yeah, I think it's got an unfortunate name, hasn't it? I think what it does is great. And it's a lot of, going back to your original slide, Rochelle, with the, what it is as an orientation. Like I'm fully aligned with all of those components, but I think it's alignment with the kind of colonial terminology around global health, and the discourse that continues to be problematic in that field is tricky. But I do think, just going back, I do think that global mental health has really reformed and responded well to a lot of those criticisms, from up at Denmark Hill in particular, but also some in Canada, and continues to change. All right. I know there are a couple more questions. I was thinking to open it up to the room. I've got the nod from Rochelle. And there's some online. I'm happy to go where you think. Sure.
Thank you very much for these really fascinating talks. I think these are all really brilliant projects. I really like the reflections. Sorry, I forgot your name, the last talk. Katie. Really brilliant reflections on your PhD. And it's always, so insightful to think about the limitations of your own study. So I've done mental health research, not really globally, but also qualitative research in different communities with very different groups like veterans. And I'm wondering what you feel about co-production approaches and how far they can actually address these limitations. Because I sometimes feel it's important, like even when you formulate the research question, to already have the people on board on whom you're doing the research, because otherwise they go like, well, yeah, maybe you're interested in that, but that's not how I see myself, what the issues are that I have to kind of deal with. And do you think like a really good in-depth co-production approach that gets the people on board very early, whether this could actually fix some of the limitations, obviously not all, but whether this would make a difference? Thank you.
Yeah, I think about it a lot. I'm at the moment been helping a bit with a systematic review of co-production and well-being papers globally, which is obviously just the most insane thing to have to try and capture in a systematic review. Both of those terms they're so kind of wibbly wobbly that it's basically an impossible task. It sort of feels like it's been set up to bamboozle me. But yeah, the co-production thing's interesting because you can't, in any kind of, I guess, speaking as a social scientist rather than as a psychologist or someone from a medical setting, there's nothing objective about the work that we do. We're trying to represent individuals by taking kind of summary average data of individual level experience. So it always feels a bit awkward. So the co-production thing is great. And obviously you want to have people from whatever community it is on board, but people are going to have vastly different opinions about their own experience, even if they've had a very similar experience from a similar community. So I guess doing the best that you can whilst also not hoping to speak for any community. And yeah, just understand. I guess it's not a limitation. I rather refer to it as kind of a complexity of the research. But yeah, it's tricky. But yeah, yes, pro co-production.
I think there's some people who have gone kind of jumped in with both feet into co-production. I think that there's an interesting discourse coming out actually from the kind of lived experience groups themselves, but also other academics around what are the ways in which the voices of people with lived experience and young people, Lorraine and I have just been at an amazing conference in Cape Town. What are the ways in which those voices can be most representative? You often, with a lot of co-production groups, a lot of lived advisory groups, you get a very specific kind of person that is represented within those groups. And what are the methods that we can use to kind of bring in a kind of broader representations of the groups that we're interested in? And also, you know, how beneficial is it for those groups versus, for example, how re-traumatizing can it be for those groups to work with us through a process of co-design, other ways or other points within the research that we can engage those groups? So I think I'm quite interested to see what's going to happen over the next few years, particularly within the field of global mental health, in terms of how we continue to centralize those voices, but the kinds of methodologies that are developed to support them. Should we take another question from within the room, or go for it? Yeah.
Just in case and for the recording. So this is from Eleanor Chapman, who says, thanks all for amazing presentations. For those who used in-country research collaborators or assistants, I'm interested in your reflections about how we can ensure equity in research outputs, especially when projects are led by people based outside of those locations. And so, like, I think this is a big reflection for all of us, but, you know, but I would love to hear how you guys are working towards that.
So, I mean, we spend a lot of time thinking about how we ensure equity. And I think what comes from our partners often has to do with support with the writing process. So that's the bit where partners tend to struggle in terms of actually writing their own manuscripts, writing their own research outputs. And so we really, you know, set aside a lot of money and a lot of time for supporting them through that process. So they don't just get to execute the research and then somebody else writes up the research. So that's one big part of it.
I was just going to say that I think it's again part of my PhD reflections of this is supposed to be an individual piece of work in order for it to be it's obviously not an individual piece of work. It's again in social science reliant on so many connections and communities, and obviously I'm working with a research assistant, but for it to be my own work I have to write up the analysis, but by making sure that she's involved and can look over my work and say, oh, that doesn't seem right, and make sure that she's part of my kind of publications and is able to kind of weigh in on the way that I've interpreted it to kind of steer me if I've gone massively off course, is how I'm kind of managing that. But it does feel sort of strange and odd, and yeah, have to speak about my own work, but it doesn't feel like mine. It feels like a part of a collaboration, even though it's my PhD and I get awarded at the end.
Yeah, I think I have similar feelings at this stage of the PhD. It is an individual piece of work in that sense that you're completing, but I think asking so I didn't have a research assistant or someone in that official capacity, but I did set up a working group that was representative of the different types of participants, so like an elder, a youth, a community member, to kind of guide and inform the work throughout. And from my experience, I think I was just limited in the engagement that I could have with them, given that I was going back and forth between the countries, and then also the funds that I had to give to them for their time as well. So I did try to do some co-analysis of transcripts just to kind of gain other opinions, but I think it would have been a lot more fruitful to sit down and do that in person. The elders in particular can't read a lot of things. And so just to have conversations about them instead. But I think that's also just kind of general limitation or a reflection of general limitations at this stage in research in your career. But then also asking kind of those you're working with what would be meaningful to them that you can provide. So if they want to be part of publications post PhD, if that's something they'd be interested in, make sure you include them in that process. I did a lot of recruitment, and I spent a lot of time through a community organization in Winnipeg, and they would like a report basically that they can use to help them gain more funding and support for their programming. So that's something I will do for them, but that's meaningful to them, perhaps more meaningful than a publication as well.
I could also say that, I mean, in the project that we're working with in Vietnam, we're kind of lucky. It's a little bit different from other contexts I worked in which we partner a lot with universities. So in any case, you hire research assistants through universities, you mentor PhD students, you build research infrastructure, you build careers of other people. So if you focus on that, you leave something behind. Whereas with our NGO partners, many of them are very frank that they would like to see some publications, but it's not something that's sort of top of their lists to be first author on publications. And for the NGO, they would much rather other things like getting funded. Yeah. So yeah.
Yeah, thank you so much for those 3 presentations. And I wanted to reflect a bit about on the hegemony of Western discourses via social media. So, everybody, teens, etc., being exposed to the language we're using and the proliferation of ideas around trauma, around anxiety, and all of the disorders that we are seeing, being so sort of heightened in the West. So I wondered, it's almost like you can't do any so-called pure research in an Inuit community anymore, because there's already the influence of that. And I think that's one facet of that hegemony. The other facet is that the healthcare workers are probably using Western techniques as well. Like we've, worked, spoiler, we might talk a little bit later, but, we've worked in Indonesia where the dominant form of treating people post a disaster for their trauma is eye tract movement treatment, or CBT. So we brought in more collectivist interventions, and then suddenly that was taken to the Clinical Psychology Association with the idea that actually, you know, Westerners actually think this kind of thing is actually maybe decent, maybe workable. So I just wondered if, as you know, the researchers of the future, if you could reflect on that sort of hegemony of Western discourses, please.
Yeah, so I think LGBT research is a really interesting space to explore this, because it's also politicized discourse. So it sits in a place where, on the one hand, there are indigenous concepts of sexual minority identities. On the other hand, the term LGBTQ+ was invented in the West, but then also being weaponized in global South countries by people saying like, oh, you know, gay people don't exist. They're invented by the West. You know, so it's a Western concept that's come over here. And so you have to take a kind of nuanced position where, yes, sometimes, you know, in your position where sometimes it helps to pay attention to indigenous language, and sometimes it actually does empower and help people to import language from outside, because it has helped youth gain vocabulary for talking about things that maybe they haven't been able to name or talk about indigenously. And they don't, you know, the participants that we work with were quite, I would say, at least with these concepts, some of them were very reflective about it. So they actually thought in very deep ways about it, which I was kind of impressed by. So one participant talked about how he was thinking about what he was, and in the beginning he thought he was aromantic, just because the flag of the aromantic sort of matched his t-shirt, and then he was like wearing it during Pride, and he realized he was not aromantic after all. And then he decided, you know, then he felt that he was more non-binary, but then he thought that he didn't really like the Western term non-binary, because non-binary only tells you what you are not. It doesn't tell you what you actually are. And so he used there's sort of a Vietnamese Chinese concept of Wu Wei, or Vô Vi in Vietnamese, where Vi means to be and Vô means not to be. And so in Taoism, if you say Vô Vi, it sort of means to both be and not to be at the same time, or to just let it be. And so he's saying that actually what I am is more like, you know, both to be and not to be, both man and woman at the same time, you know, just let it be. And so he sort of invented his own terminology for how to describe himself, you know, starting with the concept of non-binary, which he heard from Western concepts, you know. So people negotiated language in quite sophisticated ways. So yeah, that's my reflection.
I was just going to say also that just the speed with which the language around mental health changes. We started a project in Nepal in 2018, and we were referring to depression. We chose a sort of socially acceptable term for adolescents to communicate their depression or their worries, their anxieties. We used the term Mong Ko Samasya, which is heart-mind problems. And by the time we were doing the phase 3 trial in 2000, which started last year, 2025, none of the adolescents were sort of comfortable using that terminology. It was already outdated. So the sense of kind of concepts of real research, I'm finding it increasingly interesting just to sort of embrace that kind of those changes, those trends, those patterns, and sort of, I guess it's just a part of youth. And yeah.
I was just going to add quickly around the kind of, the social media effect of mental health discourse becoming so ubiquitous, and people recognizing their own experiences of depression symptoms or anxiety symptoms, and then conflating that to, oh, I must have depression or anxiety. I guess the issue remains the same, in that it still will be the people who have access to the most resources, be it money or education, that will still be accessing the services. So even if everyone is more aware of the kind of mental health issues those people who have the least access to kind of get support are still not getting the support. So even though the language is there, the need kind of remains not the same. Of course, it will actually be increased because now more people are asking for those services, but it'll be people who need the services less who are probably more likely to ask for them. So I think we need to kind of factor that into accessibility and kind of outreach because of this high level of knowledge around symptoms and pathologization.
I think also, so while we've been saying like the labels can be harmful and if kids or young people getting these from tech, I think it does, kind of as Lou was saying, it does open up space to kind of go back to localized understandings or language of what these words could mean and maybe how they were dealt with in the past. So a lot of Inuit knowledge has been lost in the last 2 generations because it's not been passed on because of colonialism and residential schools and missionaries and all of that. But in my work through probing different people who have a greater understanding of culture and knowledge and language and concepts, I've been able to kind of dig out some old words I've been told, and perhaps maybe it's through doing that we can have a resurgence of past understandings that can then make sense that aren't widely known, rather than kind of translating our terms back to them. Yeah, just one quick example. So I found in my work the LGBTQ space is quite contested. So in the past, Inuit that wasn't a thing. It didn't have a word really. It was just accepted. But with Christianity and missionaries, people are now told that's very wrong, particularly in the north. The various denominations, often multiple denominations in small places, are very strong still, and that is one of the contributing factors to the really high youth suicide rates as well. But kind of digging that knowledge out and that perspective and saying that it's okay and your ancestors did this or this is how they did that has been very helpful for community members that have found this themselves, and then from them to pass this on to kids today as part of the wellness kind of well-being programming as well.
I just want to say that I think all 3 of you are doing such fantastic, really cutting edge work. And I feel really lucky that we've sort of got to be here to see you at the beginning of it. And sort of in 10 years' time, you'll be bigger than all of us. And I will remember, Ben. We'll remember then. Just remember us little people. Okay, so I think this is the last question. It's one of the ones that we might ask other panelists as well. So if you want to start and prepare and we get into break. So I think your work in particular brings up a lot of tensions. You're sitting with a lot of these tensions, but there is also this feeling that your work is trying to change things in response to those tensions. So if you had a magic wand, what one thing would you do to change this field for the better? And then we can go tell Wellcome Trust because they're the ones with the money.
I think in the space that I work in, it's very contested as in what you call a youth program or intervention for mental health. You have to use very different language if you want to get funding or if you're using it in academic space. The kind of idea of social prescribing here as it's understood in the UK, to my knowledge, doesn't really exist in that space. And I'm not sure about the wider Canadian context, but it's not really there. And so kind of the need to have to legitimize social interventions as mental health or suicide prevention programs is quite problematic, because I found one of the hardest things in my PhD has been straddling the 2 different languages, so the academic language and then the on the ground language, and then how do you talk about that when you're trying to write? What kind of language do you use? And in my work, so for example, land-based programming, whether that be adapted to an urban setting, so you can go ice fishing on the lakes outside of the city, or on the land camps up in the Arctic where you can hunt traditionally and kill a caribou, or whatever it is that the kids want to do. That is actually a suicide prevention program, but because it's cultural, it's a protective factor against bad mental health, and it's cultural revival, and that's known and it's established in the literature. However, the language that we speak about things and the way things are called is different. So I think we need to have more understanding of that and more leniency in funding or academia or whatever space it is that you're trying to get your message across of what mental health or well-being means to people.
So I guess there's sort of different levels of answering the question. So I guess at the immediate level, I guess if you want to, if you think about global mental health and LGBTQ plus mental health, one of the biggest impacts is, of course, USAID and US politics. It definitely even influences Vietnam, where public discourse, our civil society partner cells has shifted, and people say sort of like, even Trump doesn't like LGBTQ plus people. Why should we like LGBTQ plus people? And lots of research has shut down, lots of clinics have shut down, and we even have research partners who had submitted papers and got them accepted by journals on LGBTQ plus mental health, but then had to retract them because they collaborated with a US partner, and the new administration, just didn't want anything out related to LGBTQ plus stuff. So that's the sort of immediate crisis that we deal with. I think but I guess the broader thing I would change is I would like to get past sort of LGBTQ plus research always being about crises. And it's always about sort of like, for example, in mental health, the minority stress model is very dominant. So it's always about stigma, discrimination, and bullying, and, gaining basic rights. It's always about, the same studies about, how do you, what are the negative impacts of criminalization of same-sex relationships. It's always about the basics. And never actually about what kind of life do you want to live if you don't have all of those restraints, right? Because even when we look at data from Sweden that has lots of rights and lots of freedoms for LGBTQ plus people, there's still a huge gap in mental health between LGBTQ plus people and cis heterosexual people. And that's big. I mean, to me, that's kind of obvious because not having restraints on you doesn't solve all your lives properly. You still have to figure out what kind of life you want to live. So for me, I would like, maybe for global mental health to move a little bit beyond the conversations about the sort of basic stresses of mental illness towards sort of like, if you could do anything you want to do, then what does a flourishing queer life look like?
I'll keep this brief. I think the magic wand, well, I tried to be a bit positive about it. I think that the magic wand is waving in a sense because of this massive shift towards speaking about mental health, openly recognizing its importance at all levels of society, from kind of individual all the way through to kind of government level. Whether the policy truly has reflected that and allocated the correct amount of resources still remains to be seen. But I think even in my kind of short experience within this field, globally, the shift has really become like a wave of interest in the importance of mental health. And that for me feels really exciting and positive. I think the funny thing is kind of that we're realizing that all of the effective interventions for social determinants and the kind of broader stuff is basically deprogramming all of the kind of Western capitalistic stuff we've done to society over the last 100 years, and go back to living in community and having people in your peer group who are supporting you and spending more time outside. And so it's all feels like fairly obvious stuff that has to happen, but I think people are slowly waking up to it, which feels nice.
Thank you very much, you three, for the brilliant presentations and the fantastic round of discussions. Final round of applause and then break.
Hello, hello.
Hello, welcome back after coffee. Thank you for coming back. My name is Jeran. I am a clinical psychologist and a researcher in global mental health. And I've been a research fellow within IGH for a couple of years together with Kelly, and recently transitioned into the senior research fellow in global mental health position, which is really great. Oh, we have more people coming. And so I, you know, I'm a clinical psychologist, but I study suicide and common mental disorders in low resource settings. And I think, you know, the discussion so far has been really highlighted. You know, one word for me was complexity. So that complexity is really important. And applying the global mental health frameworks, I try to appreciate that complexity using methodology that is in line with that. So really excited to and honored to chair this panel today. I think we can go ahead and start and get more and more hopeful. With we can start with Professor Ilan Kelman. Would you like to come?
Thank you so much, and thanks so much to Rochelle for putting this together and bringing us together, particularly in the context of how much difficulty and despondency there is in the world. And particularly when people always headline it with human-caused climate change, thinking that human-caused climate change leads to everything negative and only negative. Well, in that case, why worry? I might as well just fly to New York every weekend for shopping and enjoy the little time we've left, since there's nothing else to do. Or we could be more scientifically grounded, more morally grounded, and say, yes, things are difficult. Look at where we've come from, look at where we are going, and how can we effectively create and communicate such messages. With UCL, we have been doing that through art, through a series of small projects. One of them was called Moonface, and a single actor show. She wrote it, directed it, co-produced it. And with her team, we had a lot of discussions about science to incorporate science into this show, which called Moonface was the face of the moon, particularly her playing the moon and giving her the moon's perspective of moon mining. We know we are overexploiting resources. We know that we're looking towards other planets and the stars. What does that mean for sustainability, for ethics, and of course, for how we use those resources? So she gives this 1 hour sole person show on the moon's perspective of moon mining, including a lot of satire of our good old friend, Elon Musk. And one example is that one of the elements desired from the moon is helium-3. So I brought up the atomic structure of helium-3, and we translated it into the stage using cling film, which the moon then has to navigate. These are some aspects of saying, well, where do we go next? If we incorporate the moon's perspective into earthly actions, what does that mean for us? And in that sense, for global mental health and trying to do better, global mental health goes beyond the globe, with the geographic scope being the solar system, the galaxy, the universe, which leads us to universal health coverage, which we want anyway. So that's the theater. Another artistic endeavor funded by UCL was music. So I worked with composer, singer Eloise Tunstall-Behrens, and we worked out what is the trajectory of climate change science? Where does it come from? Where are we now? Where are we going? And Eloise took those three to produce a new 3-movement choral piece, about 20 minutes long. The first one being the despondency, the second one being where we are now, the third one being the hope, and then connected with a primary school in Hampstead and got the kids to sing it. We had a workshop out on Hampstead Heath, bringing the kids out there and saying, okay, here's your canvas, paint your future. So they had to use dirt and twigs and leaves. I mean, kids hate dirt, right? In order to build their future and map that onto the song which they were singing. And working with these different ages, with the adult musicians, the kids, when we think about what Rochelle said in terms of working with people she considers old, like David Osron, it's also trying to get the different messages in different ways to people of different ages, and doing that through music. So Eloise also put together a production team, recorded it, and it is a free video on YouTube with this performance, which was in the Grant Museum of Zoology just down the road. Getting different messages to different audiences in different ways. A third art science project funded by the Geologists Association had me working with a 3D sculptor and installation artist to go on walks around Norfolk. It's a tough job sometimes. And we had art science conversations about what we were seeing in terms of the past 10,000 years and the future 10,000 years of coastlines in England. Particularly when so much of the messaging about the disappearing cliffs and the encroaching sea is about climate change, when the reality, the science, is that it is about geological change. But how do you communicate this to someone that their house is teetering on the edge of a cliff, they're about to lose everything that they've ever known, where they were born, where they grew up? Oh yeah, it's just normal geological change, right? Not exactly very helpful or hopeful messaging. We've been working with art science to develop helpful and hopeful messaging, and part of what we came up with is liquid language, and this came out very clearly on this brilliant panel just before the break, in terms of understanding different cultural concepts and conceptualizations of language, of communication. And through our 3 walks around Norfolk and also Cambridgeshire, we started coming up with words like crag shift, like ghostlands, to shift the language and think about communicating what we are experiencing, what we are feeling, what it means regarding home, what it means regarding loss of home. This was an installation which the artist produced when we did an evening of presentation at the Cedric Museum at the University of Cambridge for a public event. And we're now working on collating all our results and analyses and discussions in order to write up for artistic and scientific publication. It's sort of that question about the magic wand. If we do have a magic wand, what in our language, what in our vocabulary would we change? And one of the things which I would actually change is using magic. So UCL funded one of the top UK magicians, Megan Swan, to work with me to develop magic tricks for communicating what is happening with climate change, and more to the point, how we should act, what we should do for dealing with climate change and its impacts. She put together a show. Again, she presented it at the Grant Museum of Zoology. And then I started, the past 3 years, I brought her into my climate change and health module here at IGH to give a session to the students, as we see here, about her climate change magic. Different art forms, different ways of thinking, different ways of working. And there's also other art science projects which are ongoing or which have been in the past, all around these ideas of how do we work together to change the way we're thinking and to alter, to morph the negativity into realism and optimism, realistic optimism. How do we erode, coastal erode, the negativity? How do we build homes in places which are rapidly changing due to human-caused climate change, absolutely, but also due to many other societal and environmental influences, which often get subsumed or dominated by the human-caused climate change discourse, presumptions, and often lack of evidence. Climate crisis, climate emergency, climate chaos, climate apocalypse, we hear it all the time. Doesn't make that much sense. Climate doesn't care whether we're here or not. Climate, by definition, is the 30-year average of weather statistics. It's actually an artificial construction. Many languages do not have a word for climate, which means that to them, climate change is weather change. And yeah, of course, the weather changes all the time. So why is suddenly a statistical calculation a crisis or an emergency when the real crisis is us? We are the ones causing the problems. It is a crisis of human values. It is an emergency of human actions. When we tell everyone they're going to die and that the climate is in chaos and the climate is absolutely a mess and devastating us, well, it's no wonder we have a lot of climate anxiety. When we do some of this work and we get audience reaction, or when we get reaction from people who are experiencing it, like on the Norfolk coast, we are seeing that the discourse on climate anxiety is causing more climate anxiety than the actual climate changes. Rather than eco-grief, rather than the word which many of you have heard, solastalgia, and all of the other ones, let's use art science, let's use our evidence, let's use our power, our positionalities to change the way we think, to change the way we talk, to move forward with climate hope and eco-inspiration. Thank you.
Thank you so much for this very inspirational talk. Now I think we can move forward to Professor Helene Joffe. I hope I did a good job pronouncing. Very good.
Hi, very nice to be in this forum, in this context, and I'm going to talk to you about future disaster resilience and the role of school-based interventions. This just represents the last 5 years of my interdisciplinary work with people in the Bartlett and people in engineering. And what I'll talk to you about is moving from really assessing resilience, and I'll talk about Indonesia to start with, assessing resilience, and then moving into an intervention that worked. So its effects we'll talk about as well. I come from a psychosocial perspective. So for me, resilience, unlike engineers or planners, for me, resilience is successful adaptation to adverse circumstances. And so I think we all need to obviously define our terms when we work in interdisciplinary ways. And we started with recovery from disasters, and the fact that resilience in recovery from disasters lies in systems rather than just in the individual. So each individual resides within a household system, and that in turn resides within a community system, and the community resides within a society. So this is a systems approach to resilience, and that makes the school a very important part of people's systems, particularly young people, and we focus on teenage girls. So the school builds the child and shapes the community around the child. And of course, it's a strong entry point for shaping their well-being. And it plays a crucial role in people's resilience. And this is Anne Marsden is the person who coined the term, this notion of resilience being systemic. And upon reopening post-disasters, so we mainly look at we started off looking mainly post-earthquake, tsunami, landslide type disasters, but I'm going to take you into gang warfare and war type disasters too. But we devised our intervention and did our early work on earthquake, tsunami, landslide, which has been a focus of my work for 20 years or so, and before that, emerging infectious diseases and climate change, but that's not what I'm going to talk about. So upon reopening post-disaster, schools can provide educational continuity and psychological support for pupils, and they tend to provide the glue that holds communities together. So schools are incredibly important post-disaster. And why would we target pupils' resilience, in our case, teen girls' resilience? For future resilience, children and adolescents are an ideal target for at least 3 reasons. So adolescents are one of the most vulnerable groups, and after disasters, increased risk of post-traumatic stress disorder, depression, and grief. And these vulnerabilities are exacerbated in teenage girls. So that is one reason. And of course, children impact their family resilience. We know from smoking cessation interventions that children pressure their parents to change their behavior and their thinking. And we can therefore facilitate resilience building in homes via intervening with adolescents. And thirdly, adolescents have been neglected as a group in resilience research. Yet they have the cognitive capacity, of course, to heavily influence thinking at home. And girl teens in particular need to be kept in school, not only to foster their own potential, but as a resource for future resilience building. Yet we find in the global south that very often it's the girls who drop out to look after the home with the mothers. So on this basis, we opted for a music-based intervention with adolescent girls in schools to build resilience. So why the music part? And I'm pleased Helene has already talked about the arts. So music-based interventions in particular can impact teenagers' well-being and resilience. And we have the brilliant work of our own Daisy Fancourt and Ellie Pierce, who is, I think, not at UCL anymore, but we were very, very lucky to have people who are absolute leaders in randomized controlled trials and so on, showing that singing in groups has been strongly associated with a range of qualities that yield health and well-being benefits. Singing in groups fosters social bonding, belonging, inclusion and connectivity, and positive affect. And these studies, they started off looking actually in the UK, but there's a lot of global evidence on these things. So singing in groups, choirs are very powerful mechanisms of increasing people's well-being. So song has been used as a powerful tool for risk awareness. I'd love to talk a bit more about these amazing songs like the Smong Song, for risk communication and for disaster preparedness. So it's been used globally for these things, but it hadn't previously, as far as we knew, and I would love to hear anyone who would correct me afterwards. We wanted to test whether this could extend to increasing post-disaster resilience. So we've got awareness, risk communication and preparedness, but not the next stage of making you more resilient to the next disaster. And so we devised the Recover with Music intervention, which I would love to show you. So it's just recoverwithmusic.org. We used an amazing Chilean Argentinian company where the head of the company was trained at LSE in behavioral science. And we, luckily enough, our grant was during COVID. So we used our travel budget because we couldn't travel to Indonesia. So we did it all remotely, which I think was quite good because there was a lot of building of local capacity because we didn't go, any of us, at any stage in a 4-year project. The first one was 4 years. And we used that budget to create a website and a beautiful little animation he created to show what our intervention did and how to do the intervention. So the Recover with Music intervention draws on evidence-based principles from resilience science to improve the mental health of adolescents post-disaster. And so we derived it from global studies of what helps people become resilient. We very much like the work of Hopful et al. And I must here credit also Rochelle with helping us in the content of what we put into our intervention, Tree of Life, breathing exercises, and so on, all of which you can see on the Recover with Music website. But Hopful's 5 principles of resilience we found incredibly helpful, and we've actually found that we can use them in other contexts, and that's how I'll talk to you about the other contexts in the last couple of slides. And his Hopful et al.'s notions of what fosters resilient recovery are fostering a sense of safety, fostering a sense of calm, fostering a sense of connectedness, and I put that one very high up, and the other one I'd put very high up is fostering a sense of self and collective efficacy or agency, and a sense of hope. And I think these are unbelievably important, and I really think well-being actually rests more on these things very often than on some of the things we think about. Of course, not in psychotic people who are psychotic and so on, but we were dealing with the sort of average adolescent in a school, so not clinical population. So I do see that there's a very big distinction between those two that I think we need to bear in mind. So what were our results? So we ran the Palu, Indonesia intervention in 3 schools, and we had match samples in 3 schools. And resilience, we looked at baseline at their level of resilience and well-being, and then we measured it after 1 year. And we found that post our intervention, the intervention was a 1-day intervention, very intensive, morning and afternoon, with a song. We used a consultant sort of song-based, but the intervention is all about the children building those hopeful principles, calm, hope, self-efficacy into songs that they created themselves. So it's very bottom up, and they've created these very beautiful songs. And we found that activity, and then we had later collage activities. We tried to sustain it using behavioral science and reminders. They got mugs, they got tote bags. We used whatever science we thought would come together from our past work to help sustain their resilience. And we found significant reductions in post-traumatic stress symptoms. We found reduced anxiety after the year in the people we intervened with, reduced fatalism, and an increased sense of peer support. I always think that connectivity, interestingly, and a reduced sense of family support, which was probably developmental, right, because they were getting older. And our conclusion there is creating a song and the sustained activities for the song-based groups may have given participants a medium with which to process and express their emotions, to feel agentic or self-efficacy, collective efficacy, and to bond with others in a similar predicament, thereby bolstering their resilience to future disasters. But one thing that those of you, the more scientific among us, might have noticed is no control group. As we all know, in disaster context, so we were operating post the very severe earthquake and tsunami landslide in Palu, it's very hard to have a control group, have people you don't intervene on. And there are all sorts of problems with the systematic finding of random houses when everyone's house has been destroyed. So in that one, we didn't have a control group. And also, funny sort of aspect of being an academic is we'd heard that this is an ESRC grant, very large ESRC grant. And I was the PI, and I'd heard that the person who was heading the grant didn't like control groups, and I regretted it terribly. So we got a year of funding later from the ESRC, and I then got my control group, but it's not easy to get control groups. So that's what I'll talk about in the last couple of slides. So we took this intervention to global context because I was determined it was impact was very important. This is an impact acceleration grant, and I'll try and be an impact case study for UCL. I don't know if I will or won't. But we took this to global context, and we took it beyond national hazard-based disasters. So we spent a year expanding to other displacement contexts, including war and gang-affected teens. So we trained remotely because actually we got that expertise because of COVID. We got the expertise of Zoom training our teachers to implement these interventions. So we trained 100 teachers within refugee camps in Jordan, Chad, Ecuador, and El Salvador via affiliation with the UN Refugee Agency to run these interventions in the school they work in. So some of the Chad workshops, and we did the 3 of those remotely, Jordan, Chad, and El Salvador. But we actually went into Ecuador because I was determined that we were going to get a control group, which we did. And so we had an intervention group that the UN HCR was looking after in one part of Ecuador, and a control group in another part of Ecuador where they were more or less matched group that the UN was looking after. And we trained the teachers in both, but it was like a waitlist control group. The teachers in that one had to wait to implement the intervention. So we are actually just looking at the results now and writing it up now. So the results seem incredibly similar. So we're really worried. So we've devised it in an Indonesian context with Indonesian researchers. It was obviously a joint team of British and Indonesian researchers. We devised it in an Indonesian context, thought about it quite a lot, and then we implemented it in these different places. But the results seem to be fairly similar. So the results in terms of post-traumatic stress symptoms and anxiety appear to be similar to those in Indonesia. So we seem to have reduced those. And now we've got a control group to compare it to. So they reduced more in the intervention group than in the control group, significantly more. And so we had this added advantage of the ability to compare the 2 groups. And so it seems that the psychosocial song creation intervention is very positively received in these further contexts, offering hope for fostering future resilience in adolescents globally. And I think my last slide, yes, is we hope to bring these lessons from the Global South, if that's still the term that feels acceptable, please correct me if it's not, back to more Global North countries. I'm sure developed doesn't feel right now, but I'm not really sure. So, of course, the bottom line is we know that school-based interventions that focus on mental health problems may weaken mental health, right? So that's the hot thing. Various UCL researchers working. Fuchs was a UCL researcher trained by my colleague. She's now at Oxford. And also Algairis, so people who are head of the mental health grand challenge, mental illness grand challenge. I was head of it, and it was called Wellbeing under me and my engineering colleague, but they had a big fight, and they've now, made a much more mental illness focus. So I don't tend to particularly ascribe to that. Although obviously there's very brilliant work happening within that, but we know that if we focus in schools on non-clinical population, just your average kid, we know that probably focusing on mental health problems like mindfulness may actually weaken their mental health. So I'm very pro a resilience-based focus. Here strengths are emphasized, and we come back to the hub for, we emphasize people's adolescents or children's sense of safety, calm, connectedness, self and collective efficacy or agency, and hope. And thank you, that's it. And I must acknowledge my amazing team. Yeah, thank you very much.
Thank you so much. We're looking for that impact paper. I'd like to introduce Professor Helen Chatterjee.
Thank you. Hi, guys. It's lovely to be here. I'm also feel like an imposter. I'm a weird ecologist, but I do research around some brilliant topics that have already been introduced brilliantly by Ilan and Helen: arts, community, nature-based interventions in health. And what we're really interested in is how those sorts of approaches to health can help us think about tackling health inequalities. So it's been my great pleasure and privilege to set up and help design a UKRI, UK Research and Innovation Programme over the past 5 years, working with, oh, and I've realised that my slide has gone a bit weird. There's some arrows and things missing. They're all connected. It's about connected communities. That's what you need to know. So I'm not going to go into loads of detail about the programme. It's a £30 million investment that we've grown through collaboration, largely, I would say, outside of academia, with the communities sector, to drive a research programme, which in itself, operationally, as you can imagine, is a challenge for an organisation that is used to funding predominantly academic organisations. So lots of interesting things there, I think, around power and justice and how we think about that in the context of research. But within this programme, what we were really trying to do is, we know, I mean, actually from centuries of Indigenous knowledge, that connecting communities, as we've already heard and we've already talked about brilliantly, especially from our ECRs earlier, around that power of knowledge in communities, how can we harness that to bring about the kind of systems changes that we know need to happen? So we know we've ended up with, especially within the Western biomedical model, this very siloed system of service delivery. And many people, both within those services and the people using those services, recognises the challenge of that siloing and how that is in particular an issue for when we want to think about things like prevention and tackling inequalities. So what we were really interested in is how could we harness that power and knowledge from those communities to tackle deep-seated structural and systemic inequalities in society by co-producing research together. This particular programme is UK-based, but again, I think as we've heard a lot of the themes from today, as you can see from the topics that our research projects, in total, we've had 40 research projects across the last 5 years running. We've got 12 live projects. As you can see here, they're really tackling different aspects of inequalities. Some of them are regional, some of them are population or health condition specific. But what they're all doing in each of those research projects is, I guess, trying to think about local, regional, nationally, what does it mean to think about using that community knowledge to make systems change? So it's moving beyond that idea of a tokenistic person with lived experience or patient by lived experience sitting on a committee into bringing about systems change. So every project had to have an equitable mix of different types of academics, different types of community organisations, community individuals, service representation. They had to have representation in order to get the money and to be eligible for the money, to have, for example, representation from the services that they were articulating they wanted to change. So they all had to have, people might have heard of integrated care boards. That's how our health in the UK is, of course, managed and funded and devolved regionally. So they had to have representation from the head of the integrated care board of the regions that they wanted to work in, to show that they had genuine commitment, not just from those communities that wanted to bring about the change, but also from those sector leaders where that power was held, and also, in most cases, where critically the funding was held. So I won't talk through all of the findings. We've got another 18 months to go, but I think a lot of the key findings that we've had so far, a lot of the discussions today that have been around what kind of data and evidence is meaningful in these contexts has been really pertinent for us. We use, obviously, as you can imagine, a very, very mix of methods. We have lots of quantitative data, but also really important that qualitative community-led participatory, lots of arts and creative-based data that we use essentially to help broaden our understanding of what the answer is going to be to delivering a more effective model for community health. So we're essentially coming up with a blueprint for how to deliver what some of you might have heard the neighbourhood health model. We, of course, know the answers for how to build a neighbourhood health model, but at the minute, those constructions do not include really communities. And that's what we're arguing, that's where they're going to fail. But we have got the solutions. We know that community-based solutions offer the most targeted approaches for reaching the people most in need. But unless you are bringing those individuals into those conversations meaningfully and into that systems change, then you're really never going to see that change. We have found that that's very much around needing to map those assets in those areas and then make sure those assets are integrated equitably. And that comes into things like what sounds like boring, but is actually really important. So how can they be commissioned, procured and funded in an equitable way along with other services? So that's us doing a lot of stuff around NHS business planning, which again sounds boring, but again, in order to diverse the funds into different ways of operating our health and our public services, those are the kinds of, that's how, you know, research into systems change, that's where we need to go. We also have really found that we need to make it much easier for everyone involved to understand what you mean by inequity, because everybody, of course, has different conceptions of it, as we've been hearing today. So that's really about co-locating services and those users and those communities together to share that knowledge. And that's where that idea of what you might have heard of, if you heard of Sure Start and those kind of community hub models, that's really where we've seen the greatest solutions happening, where you've got co-location of different kind of NHS or clinical services alongside, for example, the library, the pharmacy, the green energy provider, housing, also a warm room where you could go and do your washing up and stay warm. And again, we're starting to see programs and services set up that seek to tackle that. But we also know that what we found is for any kind of non-clinical, community-led based approach to health, you really have to have that economic cost-benefit argument. You have to be able to show that you are going to bring about cost savings. And I'm really pleased to say that there is so much increasing evidence around that, but that's really where we want to go next, is that we can prove that this is economically more effective, as well as being humanly more effective, because you are tackling inequality and tackling those wider social determinants of health. And I thought I'd just finish really, I guess, by talking around that co-production, because you couldn't get funded in one of our projects without genuinely being co-producing the research, but just delivering that operationally is really challenging for universities, actually. Anybody who is contractually, I'm sure most of you here have had to do that, get the university to have a contract with community organisations, NGOs, individuals. Every single one of our co-researchers were also co-investigators, which at first I just said, no, you can't do that. So I just said, well, no, we are going to do that. And they, moaned about me a lot, but in the end, we managed to get there. So having people with lived experience, community co-researchers, community organisations, as well as all the different services that you need to have involved as equitable partners, as principal investigators, brings challenges, but also really is where the solutions lie. And they've really been catalysts for just some amazing research that's been going on all across the country within the projects and outside of, and is sort of leading to then what they are articulating is what the priorities are for research in the future. So I'll just highlight one of those. I mean, a lot of it is around lived experience integration and how to do that, but also how not to do it. So lots of great lessons there. But that kind of doing research in a different way. So very much, for example, one of our projects is called Coastal Communities and Creative Health. And out of that, the community, and lots of different members of the community, individuals. I actually happen to be from Blackpool, so that's partly why we situated this piece of research in Blackpool, but individuals within the community, service providers, community organisations, all coalescing around the fact that we've got an emergent public health crisis around ketamine addiction in the UK, but actually all across the world. You'll have all seen about Matthew Perry, and you might have heard of the Vivian. So increasingly, we've got this recognition that there is a crisis. And in places like Blackpool and lots of northern places, there are huge numbers of young people using large quantities of ketamine. And you might have heard places like Alder Hey have set up a ketamine clinic. But basically, nobody knows what to do about it. So we as a community of all the different service providers, people with lived experience, got together and have been doing and continue to do over the last year, essentially co-designing a piece of research around identifying what the problem is. There are no clinical guidelines around ketamine harm, around a pathway off ketamine. Addiction services have gone into kind of overdrive and don't know what to do about it. So we said, okay, well, what can we do together to think about co-producing some solutions around harm reduction and prevention around use? Even if we can't direct funding into where we need it, things like urology and pain management. So what you may know about ketamine is that it's caused by a psychological problem, as most addictions are, but the effects are very, very physical. So you get very, very dire physical effects from addiction within often only a few months of usage. You might have heard of ketamine bladder. So whilst the services were all kind of in crisis mode by the sheer volume of users suddenly faced with this addiction problem and the resultant health effects, there's a real desire to kind of want to do things differently. And I suppose that's, I guess, in my conclusions of that idea of kind of co-producing research together when you've got a very live crisis. And I think it speaks, Helen, to what you were talking about, that in the face of a disaster, that idea of co-production, that's telling me to stop, that is absolutely the answer is. And it's so interesting that those community solutions, those arts-based solutions, that absolutely came through for us. We can't give you, if you say to a young person, for example, in an addiction crisis with ketamine, there is no clinical pathway. And a urologist will tell you there is no more effective pain management for ketamine bladder pain than, guess what? Ketamine. So that is not what a young person who's addicted to ketamine and is wearing nappies and is bleeding from various orifices wants to hear. But what they've been saying to us when we've been running co-production workshops, we've been using a kind of health systems mapping and participatory mapping approach, is that just having an opportunity to share experiences and learning with service providers, with other people with lived experience, and with senior people in systems who are willing to talk about change has made an enormous difference to their lives. So they might not be able to, in this case, it's dealing with a ketamine crisis, they might not be able to solve that, but just being in a co-production space and framing it around research for change is hugely impactful. And I suppose that's really what this programme is all about, providing those opportunities for co-produced research that isn't, I think, standard academic research. And certainly in my department, I am a complete freak and an alien. And that's why I now sit partly in the Department of Arts and Sciences, where there's other weird people who do interdisciplinary stuff. But yeah, that's what I thought I'd end with, that really importance of kind of communities in research and how we equitably make that included. So thank you.
Thank you so much. May I please ask all of our speakers to come over here for questions?
Well done, Rochelle.
Thank you so much. It was really, I think, what we needed in the afternoon also. I think listening to all these three talks is what stands out for me is that a shift from a deficit focus to a more like strength-based focus, community-focused connection and creativity. A place where people can actually find meaning in their lives and what they do, despite all the depression and anxiety and all the illness-related things that might be happening in their lives. And I think we can, go with Q&A, but I have a wonderful question that was previously written by Rochelle, I think, that I really would like to ask, because I think it's a really good opener. So I think we can all relate to that feeling where when we tap on our strengths, or when we do something, artistic, when we tap on our values inside, that moves us. I've done acting before, I've done artistic work, and I do work with clinically also with modalities that focus on values and really deep and personal meanings about what you truly care about. And as soon as we tap on those things successfully in clinical work, I see that the mood, there's a mood shift almost immediately, and that mobilizes people. So the question here is, I think, is an interesting one, and I don't want to focus on the negative, but why is it taking so long for us to shift from this deficit model to the strength-based? I mean, when we all kind of know and feel what moves us. Why do you think?
Yeah, you can take this. Can I answer? I think probably because of the disciplines of psychology and psychiatry being very, big players in the field of mental health. I'm a psychologist myself, so I'm speaking from the inside. And I think, we have focused on ill health, we've focused on problems, and then there are also wider sociological ideas about the age of anxiety and all of how, our media draws on the negativity, and that's newsworthy or bad things rather than good things, and so on. And I think, I think one thing I've learned from listening to my two colleagues here is just something about, and listening also to the younger people earlier, just there's something about moving into maybe trying to influence social media so there's not such a focus. The problem is it's all very nice that we're recognizing mental ill health, but it has looping effects, right? And so now every kid is on medication. I've got two, everyone's on medication, everyone's got ADHD, everyone's got a whole lot of things. It has a positive aspect, but also there's a whole looping effect and self-fulfilling prophecy in that. So I think the more we can actually think, I think these two talks really did, I think you've put it beautifully. It's, it's not the deficit model. We need to move from a deficit model into something else.
Why hasn't it happened before? Because I haven't been given the research grants. I'd also consider how culturally focused the assumptions might be. I don't know much about the history of medicine. When did our healthcare system actually become an illness care system? Did we ever have a healthcare system? What about different cultures throughout human history? How recent is this idea of the deficit approach and being negative? How much drives media in the wide sense and how much is driven by it? When we have positive news, and there's an incredible amount of positive news going on in terms of environment, in terms of people, in terms of society, it's hard to get media coverage for it. And when I speak to journalists about this, they say, well, the standard mantra, if it bleeds, it leads. That's what they're interested. That's what is clickbait. That's what sells. And when I say, well, but there's also this, and the journalist says, well, yeah, my editor wouldn't let it. So I go to the editor, oh, well, yeah, but our publisher wouldn't want it. I go to the publisher, oh, well, our readers don't want it. But the readers do want it. You're just not providing it. Or you're setting up the headline as clickbait in order to get, and then it's a self-fulfilling cycle. This is still all recent. What was media 500 years ago? What is media in current uncontacted societies? And what is healthcare and illness care in all those times, all those places, all these peoples? I have no idea. So to go back to my first sentence, give me the research money, then I'll do it.
Yeah, I think, Helen's point about the deficit model, and definitely when you're speaking to people who are using services or providing services, that's what they're faced with. It's the sheer volume, it's the overwhelming crisis mode of the volume of users, the state of health or ill health of those users, and a sort of overwhelming burden that creates. And I guess that's, where the community sector, the voluntaries, communities, faith, social enterprise, they have that asset-based approach, partly because they're smaller and because their funding is different. So I think there is also that element of the way that particularly in the West, the way that our public services, for example, the way that they're funded has channeled and driven that, and that you kind of, there isn't a collective action approach. Whereas I suppose what we're arguing is that there really needs to be, and that moves you automatically into an asset, because then if you're looking and working collaboratively in a co-produced way, you're looking at the assets across. So some people will have the different experiences of what the asset is, but you can co-construct what that asset is. And again, we've talked about it before, but that's, I think, where the exciting, moving to hope, is that we do know all of this from Indigenous cultures. We know about, from Indigenous wisdom, what a healthy planet looks like, and we know what a healthy human looks like. It's just that we've become so divorced over centuries. So it's how can we, where I want to go to is how can we get more of the funders to invest more into, I don't know how many people like the term planetary health. That's the word that I use, which is this idea that, the humans and the planet are interconnected, and you can't ignore that. But there's a big reluctance to fund in that way, I think. You can shift it through collective power.
Thank you so much. I love that, planetary health. It sounds like a sci-fi movie too. Yes.
That. But on the funding, I think the funding's really interesting. What Helen, I was reading your slide, the glue, schools are the glue for communities in post-conflict, and this idea of co-locating. I'm sorry, I had to run out. It's family health stuff, but the sense that our funding systems just and governance are not set out to kind of do this co-location of services. We're funding these very individual outcomes. We're not funding kind of humans as a whole, you know, human capital, and this sort of sense that really interestingly in some African countries, they're now starting to fund key transitions or key moments in a lifetime. So, for example, birth, but bringing together the different UN agencies. So thinking about UNICEF, thinking about WHO, thinking about UNESCO, to all and then their associated ministries of education and health and social care, and thinking about actually, okay, what are our contributions to this moment in this person's life? You know, what do we all need to bring to the table? And I feel like we can't really move from this deficit model until we can kind of bring, certainly in terms of funding and in terms of system planning, service planning, until we have these kinds of funding and governance systems set up to enable us to do that. I think the Sure Start programs are really, really brilliant example of what can be done. But to be able to do that on a wide level and throughout the life course would be really impactful. Yeah, not a question, just a thought.
Thank you. Yeah, we have, should we go? Let me start by. Yeah.
Hi, thank you so much for the lectures. My question is probably about the study by Helen Joffe, if I pronounce your name correctly. In terms of the music-based intervention, I was wondering if you could unpack a little bit more of why you focus on healthy adolescents, post-conflict settings. And also in terms of, there was one bullet point in your presentations where you mentioned that mental health intervention, for example, mindfulness-based intervention doesn't really benefit mental health outcomes. And then we need to shift in terms of resilience instead. But what was your actually definition in this one? Like, isn't like resilience sits in the broad spectrums of mental health and well-being? So I think I just would like to ask for some rationales and for you to unpack a little bit more in terms of your research on this one.
Yeah, so we just chose 3 schools which we matched on various criteria, and we asked for volunteers within the particular years we were working in of children. So they weren't specifically non-clinical populations or clinical population. They were just the children who were in this earthquake tsunami zone, some more coastal, some more city, and so on. So I do think, though, that there is an important point about the fact that I keep thinking about the talk about the people with psychosis. So there is, there are clinical populations that where maybe if you give them agency and all of the things that we're talking about around sort of positive ideas around hope and that, it might not really penetrate because the problems are more fundamental and deeper. So I think I'm not saying that my population was non-clinical, but they weren't chosen according to their, any measure of their, of their depression or their anxiety. They were just the kids in this region who volunteered or were volunteered by their teachers to be part of it. Of course, the questions around who has the agency to volunteer and so on. And that's the beauty of then having a control group where you can actually look at that more systematically in our Ecuador example. Then your second question about resilience, I was just citing other people's work that there's a lot of worry and doubt that many of these mental health interventions in schools, like mindfulness interventions, are actually doing, if anything, more harm than good. And I suppose I would just go back to really liking these hopeful principles of resilience, which are hope, give people a sense of hope, calm, agency, connectedness, you know, and safety. So it is just, you know, but having said that, in our intervention, we did use some mindful breathing because, you know, we in all of our contexts, we've either experienced very serious outcomes of gang war itself in Chad and Jordan, and also having witnessed people very close to you, sometimes a parent die in an earthquake. So I'm not saying that those aren't useful. It's just the evidence is on big RCTs in British schools where they go in with mindfulness. If anything, they seem to do slightly more harm than they do good. But that's not my own research, that I was just citing others.
Yeah.
Yeah, we're still with us and stuck it out. So I think we should
definitely reward them with a couple of questions. So there are two really great ones. So I'll give you both, and then you guys can choose which one to answer. So this question is asking, it's actually a student from the UCL. Oh, it's Ranjita from, yeah. Hi, Ranjita. So this question is for everyone. Can you please say something about how creative methodologies could be better supported, especially from ontological and epistemological perspectives, and how funders and publishers could support these approaches? So that's one. And the second question actually relates to this idea of funding supporting particular methods. The participant said that they would be curious to know how big organizations like the Wellcome Trust and other funding bodies, whether they align to the progression of this sort of critical space that people seem to be wanting to advance as a field, or are there, like, how do you hold that tension about what people want to fund and are willing to fund, and how we work in spite of that? Yeah.
When we talk about publishers and editors and funders and grant reviewers, it's not them, it's us. If you want to see the absolutely brilliant and marvelous work which we've done on this panel, when you're reviewing grants and reviewing publications, say that. Yes, we know what we're up against. Not everyone thinks this way. Not everyone does what you're doing. Not everyone has that creativity. Let's not forget which university we're at and the power and privilege we have, given the academic hierarchy of this country and of the world. And let's use it for appropriate purposes in order to achieve what we're seeking. When we are the decision makers, let's make the decision which we want.
Yeah, I mean, brilliant questions. I'll give you a really good example from when we were setting up mobilizing. The money comes from, it's basically top sliced from all the research councils. So all our reviewers, had to battle to get lived experience reviewers, but we did manage to do that as in equitable numbers, using my power and privilege to just, even when I said no, I just said, well, yes, and just kept being belligerent. But anyway, it was really about, though, exactly, you know, speaking to those points of, for example, sorry if there's anybody from MRC, Medical Research Council here, but every single MRC reviewer who reviewed, they'd never had so many responses to a grant call, apparently, at UCL, they did to mobilising, which says a lot about, there's a lot of people out there who want to do this kind of research, like you said, Helen, but it's very difficult to get the money, and I was in that boat, which is what motivated me to try and set up a programme like this. But every single MRC reviewer who came from, you know, MRC type background said none of them were fundable. So I can't remember how many applications we got, over 100. And are you really telling me, I mean, and some amazing applications. I mean, actually, in terms of the ones that were shortlisted, we could have funded, you know, 2 lots over every round. So that, I think, is, you've hit on a really big issue. And that was very much down to the types of data and the methods that people were using. And not really understanding power and equity in terms of co-produced research, that you can't just do a randomized controlled trial for every single study, and that you need to think about integration of other types of evidence. So I think, I mean, in a way, it's what Helen said. We have to, subvert that norm. There are going to be people out there, I think, particularly from single disciplinary subjects, who are going to, battle against this. But what I would say is keep pushing back on the systems aren't currently working. Populations are getting unhealthier and unhappier. We know that health expectation in this country has fallen for the first time now. And so it's not working as it is, but we've got some solutions that could help it work better. So maybe you want to fund that. That's what I say. I've got it. That's a Blackpool, Amazing answers, yeah.
Okay. So do we have time for the 2 questions or one more? Okay.
Thank you. I try to be really quick. I just really like the discussion about climate health and personal health. And I really like have you heard about the construct of eco-flourishing? And I really think this is absolutely brilliant, that basically to take care of the planet as a form of self-care. Because as it was mentioned before, it's not that the planet doesn't need us, we need the planet. And I think this is a really brilliant concept where there's also very nice social prescribing actions happening about, gardening and things. So I think that's a really good step forward. I just want to say to Ilan, if you get the funding, call me, because I'd like to work on this. Thank you.
Thank you. Should we finish or take one more question? You think we have time? No? Okay.
Okay. Oh, it's not really worth the time, but it was a very practical question to Helen and Joffe. Is that I've always been really interested in music and arts and sort of sports-based interventions for mental health, but like how do you train and scale that kind of intervention? Because you need actually specialized people who know about music and know about arts, know about sports, and also know about pedagogy and how to teach.
Yes, so actually, I mean, we obviously thought about that, and we thought about, for example, in our music-based interventions, thought about not necessarily having specialized equipment, and just that the voice was very important, and that you could bang, a cardboard box or a tin or whatever. And that's certainly what happened in the Chad and the Jordan refugee camps. I mean, there was nothing, there weren't even rooms, they were in open fields when I trained them, they were. And so we did have a music consultant in the Indonesian case, and she came in, and what we realized is actually that possibly when you use the music teachers within the school or any teacher interested in music, you've got much more of an insider who might sustain the intervention. So in fact, subsequent to that, we didn't we were also dealing in very low resource contexts thereafter, because we could pay her off our ESRC grant, and her guitarist, but we actually realized that there was something done. When we evaluated, we could also see that actually what they weren't, valuing the guitar or the whatever, what they were valuing is the togetherness of singing and the fun and so on. So I think, you can, in low resource settings, you can do a huge amount when people feel resourceful. So as long as you have a teacher in a school who feels he or she can conduct a music-based intervention, they seem to be able to do so. And we need to design interventions that don't require specialist equipment if we can.
I think that's absolutely it. Why are we trying to scale? Every child is a percussionist. Every teenager is a dramatic artist. Use what we have, because it's not about collecting everyone together doing the same thing with the brilliant experts. It's about us doing it for ourselves.
Thank you. I do feel empowered. I hope everyone does also. Thank you so much. So now, yeah. So we can switch to the future.
No, not at all. I think that was really brilliant. So many things are dancing around in my head, and I'm going to try not to talk about them too much. But I think that this panel feeds really nicely into this final closing session to sort of think about, well, how can we sort of build and move some of these ideas and perspectives into sort of actionable spaces and policy spaces. And we're really lucky to have two speakers who I think are sort of doing amazing work to sort of bridge that gap and divide in many different ways. Our third speaker, is, as I mentioned earlier, is not able to be with us, so we'll just have two speakers and then a bit of a discussion. And first up, we have Lorraine. So.
Great, thanks. I had hoped that you'd all sneak out and go because it's late in the day. I had responded to Rochelle's request to talk a little bit about some of my research and reflect on it in terms of policy. I sort of missed the first word about the state of the world. Oh, I'm glad the slides moved. And I thought, well, should I give you sort of the lecture on the state of the world? So we all know the state of the world. The world that we all thought was fine, you know, the Berlin Wall went down, apartheid finished, and everything was going to be just fine. Wrong. We live in a really weird time. We live in a time where our big issue is the closure of many global health provision. From my work, the catastrophic ending of PEPFAR and all this killing ourselves for a year now to try and get some monies reauthorized. Luckily, I work with children, so all the bad words, it has to go out of any project. We're sort of okay, but not. You know, people I know have had 5, 6, 10 projects closed. What does that mean? The NIH, the whole idea of research as being an issue, in a way, that's challenged. And what will that happen in terms of publishing? I publish 3 journals. If there's no research, where my article's going to come in from? We are in an era where the boundaries are shaking. We are in an era where all the things we took for granted, we can take for granted no more. But then I learned from the previous session that we should have looked at it from the other end. We've never been richer. We've never had so much more money to spend. And we've got the ultimate gift, patience. My colleagues from the NIH were giving a big talk to a large group with online media, and they said, what do we do about these cuts? And can we have a quote from you? And I said, yes, my quote, and I hope they gave my name when I quoted it, was sit tight and write, because really it will pass. And I'm very optimistic that the world does have optimism, does have good things. So I'm going to show you a little bit of my work and try and focus more on reflections of implications for policy rather than the state of the world, because that's really a worry, the state of the world. So how do I do this, Rochelle? Do I just click something? Yes, okay. So some recent areas, this is the work that I do, and I picked a bit at random, looking at interventions for child well-being. So I've been involved in a large 5-year, really wonderful, luxurious piece of work with Lucy Kluver and Chris Desmond in South Africa, where we've looked at accelerators. And it's a sort of a really new and interesting concept, evidence-based, but what we're finding is if we disband the individual approach of solo interventions and look at combinations, how is there evidence for that? What is the evidence, and does it work? And the bottom line is yes, yes, and yes. And I'll show you a little bit of graphs where if you just simply put 1 or 2 projects together, if you combine ideas, you not only get the doubling of the effect, you get more. It's like a gestalt. You actually get more. And it's a really interesting policy. You go and speak to a government and say, you don't need to anything new. You just look at what you've already got and put them together. So don't divvy them out. Cluster your work. And we even looked at which things you can cluster and what's the difference. And actually, it doesn't make much difference. Interesting, if you have a good project that is funded and working in your culture, in your setting, don't import a new one. Build the one you've got. It seems to work. Mental health provision, sitting in this room is like sitting in a warm bubble bath, because for so many years fighting for mental health, now I'm in a room, and although there's just a few long-term survivors sitting in the room with us, it has come of age, and mental health is now bona fide. People will listen to you. We've got a lot of challenges on the mental health front. To me, the big challenge is the resources. Somebody asked the question of the team before, why shouldn't we just have the same resources as any other condition has the same epidemiology or prevalence? So 20% of people have a mental health problem. Is it higher? Is it lower? Depends on which epidemiology you look at, depends on your definition. Oh, well, that's similar to cancer. So why don't we have the same resources? If we had the same resources, we could do quite a lot. Everyone in this room could run out and do lots of things. There's a big move of lay provision, task sharing. It's got all sorts of fancy words, and I go no lay, no pay. Because if you look at what happens in low-income countries, where these lovely models, usually by rich grants coming from the West, they show lay workers who they don't train, who've got no career trajectory, and they go and they do it. Even they get grannies, and they get, who are these people who they know how to talk to you? And I get quite angry. Pay them and train them. Why shouldn't they be paid? And why shouldn't they be trained? A few of the models are now starting to pay. I sat in one in Mozambique, and there was a group of people, and when you spoke to the lay providers, they were paid. She told me she got a T-shirt and she got lunch, and she got bus fare. So she walked. She took the bus fare to pay her kids' school fees, and the lunch that she was given, she ate one little bit, and she took all the rest home. It was dinner for the family. She was paid, just an appalling wage. So, lot. Our other work is with what we call cash plus care. And again, there was threads of some of this stuff beforehand. We've got very good evidence from our research that if you give a good intervention, and there's good evidence on small injections of cash. It's not rocket science. We've got the dole in this country. Go to a low-income country, give it a fancy name. If people are starving, you give them a little bit of money, they stop starving. Conditional, do you force them to do things in order to get their money, or do you just give them the money? A whole debate. But what we found is if you combine cash with care, and care to us is basically the array of psychological support that you've heard, you get better outcomes. We've done a lot of work on orphanhood. I'll talk a little bit about that. COVID-19 orphanhood, do you know that it took 10 years for orphans from AIDS to reach 5 million, and it took 2 years for COVID orphanhood to reach 5 million. We're sitting in the vortex of 2 pandemics, one after the other, and do you know that in the whole world there's only 2 countries that note on a death certificate if there's a child? Come on, what policy? When somebody dies, they put their address. Well, they're dead. They're not going to be using that address anymore. I mean, that's useless information unless it's for social class, where do they live? I mean, there is geographic, but what about their children? We couldn't calculate how many children had lost a parent in our studies by looking at death certificates. We've now changed that. We've begged, and in fact, 2 countries have now experimentally included it. And we looked at, together with the World Bank, we looked at every COVID policy. And you had to have a policy if you're going to get a reaction. Not one of them mentioned the word child. And if your name's not there, if your word isn't there, there's no budget line. So you can work it out. So I'll talk to you a little bit about our work on trying to enumerate COVID, orphanhood, and a study that we've done. There's just not enough time in the 10 minutes to do it all. Alternative care arrangements. I won't bang on my thing, but really the first the speaker who spoke about measuring institutions. I've got a big thing. I think the best thing to do about orphanages is to simply close them. Orphanages are bad for children, and we know that. So what's the world policy? Stop orphanages and stop orphan tourism. If anybody of you wants to go for a week to an orphanage and be kind and nice and take teddy bears to children, just think about what happens when you go home. If you want a high, take ketamine, but don't go to visit orphans to make yourself feel better. That's my views. There we go. Special circumstances. So I've been in Rochelle's work on child marriage and the Crank Initiative is really amazing. So it comes out of it. What are these unusual circumstances that we're facing? And child marriage is really one that needs to be seen and looked at. And there's some interesting stuff that I was approached to look at, children born from rape. And policy is interesting. The first country in the world, this country, has now allowed the children born from rape to be considered a victim. Because only if you're a victim can you have recourse to law. So you can have legal ramifications. Any of you want to read it up? It's called Daisy's Law. And Daisy, this unbelievable woman, has been able to take a case against the rapee of her mum, who was 13, and he's been convicted. So it's a whole strange, what is her mental health? Fascinating work. And my work on abandoned babies, again, what about policy? No policy on abandoned babies. And it'd be so easy to have policies. But in fact, I went to the House of Commons. Some MP said we could talk about policies on abandoned babies, and his over-enthusiastic colleague had prepared a document for me, and it was my paper. So the MP said, you should read this. I said, yeah, that's fine. I've read it already. I wrote it. No policy in this country. Lovely. So this is the COVID orphanage. This is the work we did to try and enumerate and to try and look at what are the factors associated with orphanage, and just trying to shock, I suppose, Helen's comment about, was it yours, about if they're getting the press attention? Well, they do. This is some of our data, which is interesting to look at, where we looked at the mental health of children who were orphaned from COVID and living in an HIV world, family, compared to those who didn't. And you can see, looking at any mental health problems, 2+ mental health, a depression score, anxiety score, and suicidal behavior. Being orphaned by COVID and having HIV in the family is the purple line, and it's worse in everything except anxiety, which itself is intriguing. And this is an introduction to multiple crisis. We can't talk now about single crisis and all the work. And people say, oh, I work on war children. Oh, I work on refugees. Oh, I work on HIV. It's multiple crisis. You have to extend your mindset. Another study that we're doing, the Hey Baby study, we love the name. I can't remember where it comes from, but anyway, it's a South African cohort followed up on 3 waves of just over 1,000 young women, thanks to lovely work by Ilona Tosca, Lucy Kluwer, and all of our team. And we look at teen pregnancies. We've got 3 groups: those who have a teen pregnancy, those who are HIV positive and have a teen pregnancy, and the third group, which we've now created, we didn't start off with, is a group who've had 2 teen pregnancies. So again, the multiple word coming through. And we're getting a 3rd generation of people living with HIV, because we're now studying the children of the children of the children who were born with HIV. It's a first 3rd generation group, and fascinating data. Nobody looks at fathers, but we're trying to, and we're also able to look at child development. And you know, I just put this graph up to show you. That is never pregnant in red, and never pregnant, HIV negative, and then ever pregnant without HIV, and the green is pregnant and HIV, and you can just see the mental health. No-brainer. If people have problems, they experience them. This is the slide that I referred to in the beginning, where we looked at all the interventions. We did a thorough review of every intervention, and it's evidence-based. And we looked at what happens with the accelerators when you have more than one. And this is the slide that policymakers love, which we show very clearly that if you put interventions together, you plateau after 3. So even if you're having a good effect, after 3, the benefit of adding more interventions plateaus in terms of outcome measurements, not in terms of other things like jobs. And in fact, you can start to overburden, which you can see with one of them, where it starts to actually deteriorate in terms of outcome. You overwhelm the system. And we've also done a lovely cost economic, Chris Desmond's done for us, that actually your expenditure to a person to do 3 interventions is probably something like in the region of $6. And we have the new online provision, which could make real effective stuff given to us. So in a way, I've tried to tiptoe through some of my work, some of the policy, and I'll just end by telling you the story during COVID, where we had good randomized controlled trial evidence of parenting interventions, very much drawing about the stuff that Helene's done and lots of people in this audience have done. And we tried to convert them to online parenting tips. So we all were locked in our houses. We gave the tips, simple one-pagers. We put them onto the internet. We got UNICEF, WHO, and 1 or 2 other big agencies like Save the Children to adopt them. And we had 200 million downloads. So if you want to know about scale and policy, you just have to be there, be creative, but you have to invest in the evidence in the beginning. You can't be creative on nothing. So all of the work that you're doing is you're laying the foundation. And, I'm very positive. I think everyone moans about social media and the press, but actually, if you can reach them with bad things, you can also reach them with good things. Thank you.
Thank you, Lorraine. Rosanna? Rosanna and I discovered today that we possibly were at the LSE at the same time.
Thank you. Thank you so much, Rochelle, and thank you for inviting me. And let me just preface this talk by saying that it's not going to be as boring as the title sounds, because I know that sounds dreadfully boring. So a little bit about myself. My name is Rosanna Himaz, and I'm an economist by training. So I'm an applied microeconomist. But I also, and I'll tell you how mental health or mental well-being comes into my work. I work mainly with longitudinal data. So large data sets that track the same person over time for a long time. Perhaps not as long as some of the UK data sets like the Understanding Society data set, but data sets mainly in low-income countries and middle-income countries that cover about 30 years, 40 years, which is quite sizable. And my interest in mental health came through a project that I was involved in while I was a postdoc at Oxford University. And you might have heard of this. This was the Young Lives Project. Have you heard of Young Lives? Yes. So I was very much involved in round 3. And I was a quantitative researcher at that time, trying to build that data infrastructure. Now we are on round 7. So Young Lives is a study that tracks 12,000 children, now over nearly 30 years, in Ethiopia, Peru, Vietnam, and India. And I was working on the Ethiopia data, and I was looking at orphans. And I was looking at parental death. In particular, what happens if your mum is still alive, but your father dies at different stages in your childhood, say middle childhood versus adolescence? And what impact does that have on your outcomes as a young adult, age 22? So I had about 3,000 kids in my sample, and I used, it wasn't a randomized control trial, obviously, but I constructed a treatment group and a control group really carefully using the data to look at the impact of a father dying on your psychosocial outcomes as a young adult. And I expected, particularly for the adolescents and given the research that we normally have, I expected that when the father dies, that's the main income earner in the household dying, that would have a negative consequence on children's outcomes later on when they're young adults. And this is what we often see in this literature, in the literature associated with orphans. But for the case of Ethiopia in my sample, I found something very interesting and very different. And what I found out was that a father's death in a child's adolescent years has positive, significant effects on their psychosocial outcomes as a young adult. So in their sense of agency, self-efficacy, self-esteem, peer relationships, on all these scores, the children perform better than children for whom both parents are still alive at age 22. And I mean, of course, this was surprising. So I did a million robustness checks, as we economists do. And here what I have is basically the type of data that I was looking at, collected in 2002, 6, 9, 13, 16, and 2021. Alongside the quantitative data, we also had a longitudinal qualitative panel. So I went into the qualitative data to see what was happening here. Can I actually explain what was happening? The qualitative sample was smaller than the quantitative sample, but we had children there who had been orphaned. And what you realize when you read the transcripts of these children is the positive adaptive behavior of these children in that low-income context. Mind you, this was a pro-poor sample, right? So we're talking about children in poverty here. There was a lot of indicators to say that they positively adapted their behavior once their father died. So as an adolescent, you had to step up, you had to start working after school. And there was one case where the grandmother basically says, and the grandmother was the main caregiver in that case. The grandmother was basically saying, I've told my child, now your father's dead, you better behave properly so that you don't sort of embarrass me. And you know, I deserve better. I'm doing all this for you. So step up, behave properly, don't be with bad friends. So a lot of things like that actually changes the child's behavior, motivates them, and a lot of things associated with positive adaptive behavior, like trying to find a job after school. Now, the key thing, though, was that the kids in my sample, the orphans, their developmental context didn't change. So their mum was still alive. They still went to the same school. They weren't sent off to an institution. The context, the developmental context didn't change. The kids for whom it changed, they probably dropped out of the survey, right? Survey attrition wasn't a big problem. And the statistical characteristics of those who dropped out wasn't significantly different to those who stayed. However, I haven't captured the ones that dropped out. So I don't know what happened to the children whose father died and then they went off to work in Addis Ababa as a maid or whatever. So I don't have those kids. But for the kids for whom the development context remained intact, they actually had positive outcomes at age 22. And that sort of resonates with my own sort of personal experiences as a child, because I lost my father when I was 15, and I could sort of understand when I read this stuff. Yes, I can see where that's coming from. I'm not saying you're not unhappy. I'm not saying you don't have. I'm not saying that I still don't sort of break into tears when I think of him. But what I'm saying is that you do develop this resilience because, particularly in contexts like Ethiopia, that is probably also what is expected of you. And if you ask these kids about, what do you think of your father dying? In one of the surveys, the child basically says, this happens, this is life. So there's quite a lot of maturity in there in how they accept life and death. So the context matters, and the developmental context matters, and the money matters, right? So you still have your mom or your grandmother or some sort of financial support to carry you through. And this got me really excited because what I then wanted to figure out was, okay, so something bad can happen, a shock can happen, an adversity can happen at the local scale or at the aggregate scale, right? Like a tsunami, an earthquake, COVID. How can we then facilitate or create an environment such that, or create the context such that you actually can support positive well-being outcomes. Create the, what was the word that you used? The deficit. Change the deficit into a surplus. Now that's economics, so I can understand. Right. And since joining UCL, or a bit before, since 2019, I've been trying to merge these longitudinal econometric techniques and findings into the world of disasters. So a lot of disaster risk modeling, a lot of impact modeling in this disaster sphere still looks at impact in terms of building damage, infrastructure damage. If you bring socioeconomic outcomes, it's mainly in terms of number of people who died, number of injuries. GDP, but nobody really looks at the individual, the household, mental health, at sort of lived experiences, right? And you can capture some of this from microeconomic data. So my work at UCL has basically been about how can you bring the microeconomics and that modeling into the risk modeling sphere. And in particular, the next piece that I'm going to talk about, I'm going to stop after this, is a current project that I'm leading. And this is about, can we actually introduce innovative financial solutions to support better post-disaster long-term mental well-being? It's post-disaster health, but I'll focus on the mental well-being aspect now. We all know, as Lorraine said, and as all of you know, funding cuts, fiscal constraints. We're living in a world with all these cuts. So we need to think of how can we actually better spend the money when we do the interventions that we do. Now, I chose Indonesia as my case study. This project is based on Indonesia. Indonesia has one disaster every month. It's in the Ring of Fire. So you've got an earthquake, tsunami, a flood, a volcanic eruption. You just have it literally every month, and then you have the major ones like the 2004 tsunami, or the Cianjur earthquake 2022, or the Palu tsunami and liquefaction. And they're multi-hazards. Often it's not just the earthquake. It's earthquake causes, landslides causes, flooding causes, tsunami causes, epidemic. Right. And the focus in this project was to look at long-term mental health impacts. So Indonesia, because it has a disaster every month, they have quite a good infrastructure for emergency support. But that's just it. It's emergency support. So there's a lot of emergency help, but then once 6 months later, everything dies down and it's just business as usual. So if you're still suffering from trauma or any of the mental well-being impacts, mental health impacts of the hazard, it's basically you're just absorbed into the usual financial system. So this project is about whether you can actually introduce social impact bonds. Can I just have a show of hands? Who's heard of the word social impact bonds? So we do have some people. Yes. We have some people who know what social impact bonds are. These are instruments or ways of financing that has been introduced in high-income countries, and a few cases in the UK, a few cases of where it has been successful in countries like India and other low-income countries, but never for the post-disaster context, or never for a post-disaster context. So my last slide is, I'm sorry, this is cognitive overload probably as the lost talk, but I'll try and make it as entertaining as possible. This is my last slide. So this is what a social impact bond looks like. Let me just walk you through it very quickly. So this is, so I said that, like funding is a problem. So we need to try ways in which we can leverage funding from the private sector, from the philanthropists, right? Now, often these social investors are unlikely to give the money without expecting a return. So we tell people, look, there's a social project, right? There is this, there are people after the earthquake who are suffering a lot of, mental health issues 6 months later. We would like you to fund a project an intervention to make their mental health outcomes better. But then, of course, we'll give you that money back with maybe a small return, maybe not the market rate, maybe something, because this is a social investment, right? So we'll give you something back. But the government says, the government or whoever who's saying this, often the government, they say, we'll give you the money back only if the project is successful, if it meets particular outcome metrics. And it's up to the designers to decide what metrics you want to pick. So you see how exciting and clever this is on paper, right? Because what this means is that the government pays, but pays only if the project is successful. And if it's not successful, the government doesn't pay, which means that there's an incentive for the social investor to make sure that the funds that they give are utilized properly. So they give it to someone who's organizing it, and the service provider, I don't know, Red Cross, an NGO, the service provider has reputational costs, so they're incentivized to provide the service properly and to make sure that the mental health outcomes are delivered or are achieved, are realized. So it's an outcomes-based contract. So it's not just about inputs, but it's outcomes-based. And on paper, it can actually work quite well, right? So our project is all about, can this actually be introduced to the Indonesian ecosystem? Because you do find a lot of money lying around as corporate responsive, what is it? CSRs, corporate social responsibility funds. So there is a lot of money there. There's a lot of zakat funds. And people don't know where to invest it. And people want to reinvest these things. And it's an ideal context for this type of outcomes-based approach to work. So I'll stop there, because I think that's a good place to stop, and we can talk later about, is it feasible? Does it work? Are people excited in Indonesia? But this can come later. Thank you very much.
I've been trying to get my husband to explain social impact bonds to me for quite some time, and he has not been successful, but you have, which is really great. He's not listening, so it's okay. That was really lovely. Thank you both for such great presentations. Are there any comments or reflections from the audience? Yeah, Chair. Yeah.
Thank you so much. It was really lovely to hear. I just wanted to say for the second talk, I think this is really fascinating, both the social impact bonds, but also you're maybe familiar with the work of Andy Rasmussen, who showed that actually in post-disaster settings, it's not the disaster or the trauma itself that causes the PTSD outcomes, but the unmet needs that the trauma causes serve as a mediator between what happens and the outcome. So what you talked about really reminded me of that. And it's really striking what you said earlier about this, the finding of losing your father and, the positive outcomes. So thinking about that as well as adversity and, what is it mediated by, you think? So what to make out of this? And Rochelle, you gave an example earlier also about the kids' illness and how it's turned to be empowering for the moms. So what do we make out of these stories? How do we utilize them? How can we capitalize on them, actually?
Quick first. I'll answer your second question first. How do you capitalize? So what my work has shown is that there are existing infrastructures and structures within the communities that we found the children in that just have to be strengthened. So my take would be identify what is already working in those communities and strengthen them. So in Indonesia, for example, when we were thinking of mental well-being intervention, and you talk to people, they say that some of the people that we spoke to, they said what works is just, communal prayers in the mosque. Just build us our mosque again, and that is what we want. So what they then wanted was that the community, the not interventions, the sort of the support structures that they were used to. With regard to your second question, that's very interesting. So with this, your question precisely, I think, if I recollect it correctly, was that you have the immediate impact of the tsunami, or you have mental well-being outcomes caused by the hazard itself, and then you have all these other proximate things, like you don't have a mosque anymore, you don't have a temple, your schools are destroyed, your livelihoods are destroyed. So this is what David was talking about earlier, I think, the inside versus the outside. So in a lot of the impact bonds that were successful in the UK, they often couple mental well-being with employment as well. So it's a mental well-being and employment, mental well-being and homelessness. And that, I think, so that means your metrics, your outcome metrics would not only look at a better mental well-being or mental health score, better anxiety score, depression, but it'll also look at employment, how many jobs have you applied for, or have you successfully worked for 3 months or what. So they couple things.
First of all, that was just, I loved what you were talking about, but I think what we have is a poverty of concept. Because really we're so busy giving negative labels and all this and listing, if you look at anxiety, depression, but to me what you were describing was a new idea of something I suppose I'd call grit. That we go in our lives and nothing happens and we're okay, but suddenly something happens at us. So a disaster is unforeseen, unplanned. And then what happens? Well, some people rally. I mean, look at your data. They didn't ask for a death in the family, but when it happened, some people rally. So we've got this human concept of grit, and maybe we should start measuring and having a level of grit. So it just feels like it's some kind of facility, and you've gone even further to say that we can build it. So we've got this void on concepts. It's something staring us in the face, and we're so busy counting bad things we forget. So I think we need to expand this positive mental health thing.
It just feels very much also, I don't need the mic. Okay, that this idea of care plus interventions, that actually is just sort of like looking at, both of you are saying, this is what's in the world that people have and they use that scaffolds well-being, that's, and can we not just give people more of that? But that doesn't fit with an interventionist logic. So this is the thing that I think sometimes we get bound up by, because we're within an aid infrastructure, and infrastructure and logic is interventionist. But what everybody in the room today has actually been doing is saying, actually, people live in systems, they work in systems, and we should just rebuild and repair and strengthen systems. Can
I just quickly add to that point? So what you're saying is quite right. So you find, I'm an economist, but I'm now criticizing them. They focus so much on randomized controlled trials, which is fantastic for looking at effectiveness. But the outcome people often focus on is pretty narrow. Now, when you do something like a social impact bond, or in your work, Lorraine, the outcome can be that mental well-being outcome, but it can also be in terms of the process. So the impact can be in terms of the process, impact can be in terms of the system, relational. The impact is not just the outcome. It can be across many dimensions. And perhaps we should measure those dimensions as well.
Yes, I mean, Lorraine, I think your term grit is what resilience is, right? So that's what the whole social science of resilience is, the social science of grit. So that's, but we need to focus on that rather than focusing on a deficit model of all the terrible, all the terrible outcomes. But I mean, I think both your talks were incredibly interesting. And I mean, of course, that demonstration of resilience or grit is such a lovely one to take away. I wondered if your assumptions, maybe from your own childhood, clouded that, because I wondered, actually, I was sort of worrying for men, that men are quite, dispensable in a parental hierarchy. And therefore, your assumption is that they got grit because they didn't have a father, but maybe they lost an abusive father, or maybe they lost someone who didn't actually emotionally shape them or feel important. So I think you have to be quite careful with your interpretation of that, but I'm sure you've got all sorts of other indices that help you work that out. Yeah, I think that's enough.
Yeah, so it is a sample of 3,000, and father's death was not too uncommon. So I think at least 15% of my sample had fathers dying, and like you say, you're quite careful to make sure that, because you want a causal interpretation, right? So parental death has to be as good as randomly allocated. So you do all sorts of a battery of tests and all that to just ensure that the results are saying something called. You can, yeah, because you can see, you have things like how often do you see your father, about substance use, about incomes, because this is longitudinal, so you can actually track the before and after. Whether they are violent domestically, that I think the later surveys capture some of, but I didn't have consistent data for things like that. Grit is interesting. They introduced grit once the children became older. So the later surveys didn't have a grit measure. So they did actually have a validated grit measure, but I couldn't use it. Yeah. I can't remember now, but I do remember we did quite a lot of work on it, but it's all documented.
Did you look at gender?
The sample size was too small to split, but no impact if I put a dummy. Yeah, no differential impact. Yeah.
My question was, as you might imagine, around the finance. So I think there's a lot of interest around the role that social impact bonds could have, isn't it? But my understanding is that, like you say, a lot of the examples, it's quite small scale. It's about returns around, say, employability. And I suppose my question is, what do you think in terms of that private finance, how could we leverage more of that into health and community in the way that, for example, maybe this is just too ambitious, but the way that we see it in, for example, buildings and infrastructure? Do you think there's any chance of that? And if that was possible, what kind of investment are they going to be making? What's going to leverage that? What's going to persuade private finance to invest more in health and community, do you think?
So in terms of Indonesia, I think the people who have been interested in it at the moment are mainly the corporate social responsibility, CSR funds, rather than banks or private finance in that sense. There's interest, but the problem with Indonesia is mainly with the outcome pair. So we feel that there is private finance, but the promise from the government is a bit difficult because they've got a disaster ministry, but the finance is handled by the finance ministry, but health is handled by the health ministry. And then the local aspects are handled by local government. So that sort of fragmentation, we have to sort of think around how to, if you're actually designing an impact bond, that has to be thought through. You need to get everybody on board. And then that's something our Indonesian partners are currently working on.
I mean, most Western business will have a CSR by law. They have to, otherwise they won't get the tax breaks. That's why, of course, loads of business wants to have location in the UK. But what we have found is it's tiny amounts of that CSR budget. We're talking like 2 or 3 grand to fund really small scale local interventions, which is very welcome. But it's the scale of it, considering how wealthy they are. So it's, I suppose what we're interested in is how could you tip into that? It's going to be, I guess, economic arguments.
Turn that into an advantage. So if something is divided up between all these ministries and the effect is everyone's anaesthetized, the other way is to flip it and to say, actually, if you each give a little bit and you can calculate that and you all join together, it's not going to hurt all your budgets. And I'm quite skeptical about private financing, just because to me, well-being is a right. And the problem with private financing is that they need to get something out of it. And the motivation and the enduring provision is worrying. And you see that, for example, with cash transfers, it started with private, but now it's government. In countries like Lesotho, they can, funnily enough, they can find the money, even though they're the poorest country in the world. And when the comunidades, which is the cash transfers in Latin America, they found that the governments would stand or fall if they would stop the transfer payment. So I'm a strong believer that it should come from taxes, because it has to, the thing about it is it doesn't matter how, if it's small, but it's about regular and reliable. I would go down the path of a human rights. It's your right to get those social payments, not the will of some, Amazon.
It's the football clubs actually in the UK that are doing the most interesting stuff, isn't it?
It's an interesting thing, Lorraine, because I guess, and maybe this sort of maybe connects to how Lou sort of brought us to think about activism and the role of activism and collective mobilization. I often sort of feel like, it's not just the state, but these big institutions or these big sort of companies become institutions of themselves. They hoard wealth. And as much as we can sort of, make demands of the state, and we should be making demands of the state, I think we also have to be making demands of these big companies that are basically taking money out of the state so that the state has less and less and less and less. And it's about how do we see our social responsibility in relation to making demands of all of the different spaces that are sort of contributing to our health. So I feel like there's an opportunity there. I don't know necessarily. I always thought CSR could be great, but it's not something that the general public knows about, right? And so then that's why they're able to hold it over our heads and make it so tiny and meaningless, because general populations don't know actually you're required to be giving back to these communities that, so it might be an interesting thing to think about over the next few years in relation to expansion of big tech companies and what sort of demands we start making of these structures that become like states, have more money than states.
But it's a bit of a worry, like your future health strategy is in the hands of a few mavericks, and some of them, take for example Gates, chooses to share funding, but then overnight, you asked me about the state of the world, overnight he gets divorced from Melinda. So anything that's really soft or psychosocial or women or children, he says, no, he wants to do that, that's Melinda's. So the nuance of their psyche will determine global health policy. I think that's a bit of a worry.
I suppose the wider context, though, is that at the moment, there's no money at all given to long-term mental well-being, zero. So do you want some money some of the time that helps one earthquake or one tsunami rather than nothing? So I don't know, it's a difficult balance. Please go ahead.
Hi, thank you very much for the fantastic presentation. My name is Valentina Yami. I'm a lecturer at King's College London, working on global mental health policy, governance, and financing. So very much interested on the impact bond. My question is for you, Rosanna. I wonder whether you can tell us more about the context of your research in terms of the sustainability of your research and the appetite for impact bonds in humanitarian settings. specifically targeting mental health. So impact bond, we know that they are considered like small pot of money, so additional fundings on the top of the core funding that the public sector should be providing. I wonder whether you can give us a little bit more of the context where this study is situated and the sustainability soon after. And if you can tell us more about who are the stakeholders that you're talking to and their motivation behind it. Thank you.
Thank you. So this is UK ISPF grant that's funded in collaboration with the British Council. And the purpose of this particular project, it's a 2-year project. This is just to check the feasibility. And my partners in Indonesia are the Resilience Development Institute, and they are very well connected with the government agents and with the communities. So this is mainly a feasibility study to introduce this. The next stage, once we've done the feasibility assessment and once we've narrowed down what exactly is the mental health problem that we want to address, that can be, and this is the other point as well, you should be able, if you want private sector money, you need to be able to have metrics to say whether it was successful or not. Otherwise, the private sector doesn't get their money plus the return, right? So, so what our study involved was we were mainly looking at high impact, low probability events. So these are like earthquakes, major floods. And impact bonds take time to develop and time to implement. So it works, it's not just a one-off cash grant. It takes about 3 years, 2 to 3 years, or even more, sometimes like 2 to 10 years, for you to see whether it worked and whether the metrics were, whether the outcomes can actually be ticked off. So it's best suited for the type of hazard that happens every 5 years, maybe. And Indonesia has earthquakes as frequently, so it will work, right? It's not like once, an earthquake doesn't happen once in 600 years. It won't work for seasonal floods. So what our colleagues did was we're mainly looking at post-earthquake recovery. And they have at least 10 earthquakes a year in different parts of the country for this to be good. One of the most sort of suited places for this impact bond setup, this approach to work, would be towards sort of rebuilding of infrastructure. So rebuilding of housing, maybe rebuilding of their community health centers, the primary care centers. That's where it'll most probably work. And indeed, our field work, when we actually talk to the communities about what was most important for them from a mental health perspective, what they said was the point that you raised, which was, yes, we are still traumatized. The minute there's a slight tremor, our children just run out. Nobody wants to sleep next to a wall anymore. We've moved our beds to the middle of the room because we're still traumatized. You have that. But what really bothers us is that our children's schooling is affected, and my son has to find work because we can't afford schooling. It's all the proximate after effects, our livelihoods, and some physical health as well. I've now lost my leg, so I can't do what I used to be doing. I can't be a bus driver anymore. So I've got to say it's about livelihoods. So I think what would... So that's the context of our project, in trying to figure out at the community level what's really important. What do service providers think is important? What does the government think is important? Because this involves so many stakeholders. So talking to all of them and then getting them together around a table and thinking, okay, which of these problems do you think is the most important? You tell us what the problem is, and we'll get our colleagues from Go Labs in Oxford and other places, and the UK and social finance in UK, and we'll figure something out. But we just want everyone to be equally invested so we can align their priorities. And then the next stage would be a larger grant to pilot it, and then see how it works.
That is really, really exciting. I just want to end with one question, unless someone in the room has a burning one they feel they need to ask, because we are at 5:30. It's been a long afternoon, but hopefully a really, encouraging and insightful and exciting one. I definitely have felt that way listening to all the talks. So my question to you both, as we wrap up, is if you could give us sort of like 3 tips about how we ensure that our work has meaning in the context of the real world. I think that would be a really nice way to end the day together. I use the number 3 because I was raised a Catholic, and so the Trinity is ingrained in my brain, but it doesn't have to be 3. It could be as many or little as you think of.
I can't answer for anyone but me, but I don't see this jump between work and meaning because I don't see it as work. I only do what has meaning. And if it happens to be work, that is what I do. So that's always been what's guided me. So I do what I care about. And I think that's a privileged position to be in. But everyone should strive to do that because you're passionate if it's what you want to do, rather than if you're told to do it.
How can I add to that? Well, that is so true. I suppose I get the most meaning out of just solving problems. So it's not just defining problems, but trying to find a solution to that as well, and an actual problem that's felt by people. So just solve a problem.
I think those are both beautiful ways to end. Thank you so much for wrapping us up, and thanks to everyone for their time today. Thank you. Yeah. This is just fun for me. I get to hug people I like and bring work to the world. And thank you to everyone who stayed with us online till the very end. We're really, really grateful. Today was recorded. And if people are okay with sharing the full slide deck, we'll share that. But just a huge thanks also to IGH for supporting this event, and to James and Carrie and Caroline for all their support in sort of getting everything together in the hidden bits and pieces. They're not here, but on the recording, I want them to see that we really are so grateful for the time and effort and support they've also made. So thanks all. Please go and enjoy the rest of your afternoons. Thank you.